Is the audiovisual okay now? Can you please confirm? All right. So, fine. Okay, perfect. All right. So, digoxin, can you type? Very good. So, it is digibind. Beta blockers. Beta blockers. Very good. Glucagon. Benzodiazepines. Benzodiazepines. Fluma. Zenil. Morphine. Naloxone. Right? Naloxone. Methanol or ethylene glycol. Formipizole and ethanol. Both are correct. India mein we have ethanol available. Abroad, formipizole. If both are given in the option, you mark formipizole. Tricyclic antidepressants, salicylates. We just did that. Acidic drugs. The antidotes are bases, which is sodium bicarbonate. Sodium bicarbonate. Paracetamol. Paracetamol. N-acetyl cysteine. N-acetyl cysteine. Heparin. Heparin. Protamine sulfate. Warfarin. Vitamin K1. Apixaban, XA. So their antidote should contain XA. Andexanet alpha, XA. Okay. Dabigatran. Idaru C. Zumab. Those who understand Hindi, it is daba ke daru they say. So daba means lot of alcohol. Daba ke daru is the Hindi version for alcohol. So remember, dabigatran, it is a idarucizumab. Cyanide poisoning, recently asked, INICT exam. Okay, recently it was asked in the INICT, what is the antidote, which is not given. So what all can you give? You can give amyl nitrite or sodium nitrite. You can give sodium thiosulfate. It has to be combined together. Okay, nitrites plus sodium thiosulfate. And what else can you give? Hydroxocobalamin. Very, very important. Methotrexate. Folinic acid. Other names are citrovarum factor or leucovorin. All names for the same antidotes. Arsenic or mercury, you can use dimer capron. So make a note of this. Is a very important list which you need to know. Next one. Pinpoint pupil is suggestive of poisoning with. So pinpoint pupil. PPP, pinpoint pupil, which is a drug which can cause pinpoint pupil. What's after folinic acid? Folinic acid, other name is citrovorum factor. Another name for this, or leucovorin. Okay? Same. names for the antidotes. Okay, all right. Let's go to the next one. Pinpoint pupil is suggestive of poisoning with. No, not barbiturates. Pinpoint pupil. Okay. Benzodiazepines, it is not in the option. It is DDT. Atropine. Atropine क्या है? Atropine is a atropine causes mydriasis, not meiosis. Pinpoint pupil. So the answer is DDT. Organophosphate poisonings. Organo, atropine, belladonna, same thing. They both cause, ancient times may women used to put atropine in the eyes to make it more beautiful for the mydriasis. So atropine or belladonna is the same thing. They both cause mydriasis. Barbiturates, they don't have any this more for common effect. Pinpoint pupil, at least it is not there. So the drugs which can cause pinpoint pupil, remember PPP, 1P stands for organophosphate poisoning or carbamates. Second P actually is a painkiller, which is your morphine. Morphine can also cause pinpoint pupil, right? And third P is for a condition called as pontine hemorrhage. So a patient comes, you have to differential diagnosis hoti hai pinpoint pupil. So how do you know? If there is a carbamate or organophosphorus poisoning, what else is going to be there? There's going to be increase in the secretions also. If there is high increased secretions, that is going to be diagnostic of poisoning with organophosphate. ठीक है? So remember organophosphate के DUM dumbbells. ठीक है? Dumbbells. ठीक है? So it causes all these cholinergic, all the actions of cholinergic, they are highly elevated with this. So increase in the secretions, they're going to be, cholinergic system causes contraction everywhere, increased secretion everywhere. Only depressant effect is on the heart. Remember, everywhere else it is contracting and causing stimulation. Okay. Organophosphate poisoning, OP poisoning, organophosphate poisoning. What is the drug of choice that we did right now? It is atropine. What is the route? Emergency may always your route is IV, 2 milligrams every 10 minutes. Till what time you have to see patient may that now the effect is going to come. That is called as atropinization. The most common question, most common signs of atropinization is mydriasis. So you will see that pupils are getting dilated. What is the most specific? That is the respiratory secretions start decreasing, or the secretions, they will be decreasing. So you will have dryness of mouth in that patient. So this is the most specific sign. Most common sign is mydriasis. Pupil, you can see the pupils have started dilating. The most specific drug for OP poisoning, as I said, it is your acetylcholinesterase reactivators, which are your oximes, PAM and DAM. The drug of choice is atropine. The most specific drug is PAM and DAM, but they are contraindicated in carbamate poisoning. Okay, these are the important points about organophosphate poisoning. Okay, going to the next one now. Anticholinesterase, the same question. Abab, can you make out? Tell me the answer to this question after all the discussion that we have. Anticholinesterases are ineffective in. Very good. It is carbamate poisoning. So this is the question asked. So you can always now know that it is not effective in carbamate poisoning. All right. Which among the following is contraindicated in myasthenia gravis? Tell me. I explained it to you right currently only. In the first, when I was telling you about the botulinum toxin, I told you that this particular drug, yes, aminoglycosides. Why? Because aminoglycosides, they also cause a decrease in the cholinergic secretion, and this is not going to act on the NM receptors, and there is going to be decrease in the contraction of the muscles. Already myasthenia gravis patient has a relaxed muscles. His contractions are not proper. There is auto antibodies against the NM receptors. So therefore, you will not give any other drug which has the same action, like aminoglycosides or any drug which is causing, let's say, respiratory paralysis or respiratory depression like morphine. We don't give them. Then which drug is used to differentiate myasthenia gravis from cholinergic crisis? Very good. Edrophonium. It is a very short-acting drug, and this is used to differentiate myasthenia from cholinergic. And this test is called as the tensilon test. Or ये question है diagnostic test or a tensilon test. So here you give edrophonium. Because it is, why you giving it? Because it is a very short-acting agent. Within just action is in less than 10 minutes only the action lasts. And you're going to give very small dose, 2 milligrams IV. And what if the patient improves? This means that the patient has myasthenia gravis because you're giving edroponium, patient is improving. If the patient is worsening, that means you're over giving your drugs. So that is because of the toxicity, because of the drug itself, weakness because of the drug itself, caused as cholinergic crisis. Okay. Now, treatment for myasthenia gravis. You have to give cholinesterase inhibitors, right? But you have to give reversible ones. So what is the drug of choice for myasthenia gravis? We have longer acting agents or quaternary compounds which do not cross the blood-brain barrier. We have, you can give neostigmine or you can give pyrido, very good, pyridostigmine. Pyridostigmine is still longer acting as compared to neostigmine, but you already also have to give atropine to the patient. Why atropine? Because it is going to block the muscarinic receptors. Here your action is only desired at the nicotinic receptors, not at the muscarinic. So to avoid any muscarinic side effects, you have to give a muscarinic blocker, which is atropine. Then you can give other immunosuppressants like corticosteroids, prednisones. You can give azathioprines, etc., cyclosporine, right? That can be given. Plasmapheresis to remove the antibodies from there, immunoglobulins, thymectomy, surgery. So all this can be done for these patients. Okay? Now, the drugs contraindicated. So here is the list of drugs which is contraindicated for myasthenia gravis. You do not give any drug which is going to further decrease the contraction of the muscles like neuromuscular blockers, aminoglycosides, calcium channel blockers, morphine because it worsens the respiratory depression, magnesium sulfate. Magnesium is always opposite to calcium. Calcium causes contraction, magnesium causes relaxation. So any of these drugs are absolutely contraindicated in patients of myasthenia gravis. All right. So this is drugs where you should give neostigmine and where you should not give neostigmine. Okay. So what are the areas where you have to give atropine? Because यहाँ पे muscarinic action. So you have to, atropine is required, muscarinic action. Post-op paralytic ileus. Actually, a second, this is opposite. It is not required here and it is required here. So wherever you don't want a muscarinic action, you give atropine. Where you want a muscarinic action, you don't give this. Okay? So it is not required, okay? Or it is required where? Post-op paralytic ileus and urinary retention. So it is required myasthenia gravis में because only one nicotinic action. Cobra bite में because again you want only nicotinic action, and when you want to reverse neuromuscular blocking action. Please correct this one. ठीक है? So not और yes को उल्टा कर लेना, just reverse it. Atropine is required in myasthenia gravis, cobra bite, and where you want to reverse the actions of neuromuscular blockers. So atropine is not required because there you even want the muscarinic action, muscles ka action you want in post of paralytic ileus and post of urinary retention. Now, these are some quick one-liners which have come in the previous exams. So let us quickly go through this one. Drug of choice for xerostomia. Xerostomia is dryness of mouth, okay? Dryness of eyes. And it's normally there is a condition called as Sjogren syndrome where there is dryness of eyes, dryness of mouth. So you want to give something which is increasing the secretions like lacrimation, etc. So one of the drugs which increases is pilocarpine. So remember, dryness of mouth hai, dryness of secretions hai. So drugs which increase the secretions are your cholinergic drugs. Pilocarpine and recently, and the receptor here is M3. And the most specific drug jo bani hai iske liye, that is cevimeline. Cevimeline. Okay, it is also a M3 agonist. Pilocarpine, cevimeline for xerostomia. So this was asked. Narcoanalysis. Narcoanalysis where you want like there is a, let's say a terrorist or some bad person you want to interrogate, the police has to interrogate, and you want that he or she should speak the truth. So you have to give some drug to that person so that they speak the truth. So the drug you can give here is scopolamine because it makes the patient very dizzy and he can't lie easily. Okay, scopolamine, it is a depressant, seen as depressant. But remember, if you're asked about the drug of choice for narcoanalysis, it is thiopentone. You can give scopolamine, but the drug of choice for narcoanalysis is thiopentone. So this can. Oh, can you still see? Stuck again? No, what is the matter? Are we back? I'm so sorry. I don't know why it is disconnecting again and again. Visible? All right. Okay. All right. So drug of choice for bradycardia. Drug of choice for bradycardia. Atropine. Very good. For bronchial challenge test in asthma, what we give is methacholine. Okay, methacholine. Drug of choice is methacholine. Maximum nicotinic action is seen with the drug carbachol. Nicotine agonist, which is used actually in the smoking cessation. So we have nicotine, we have varenicline. These are the nicotine agonists. There's another drug that we use for the smoking cessation, which is that is bupropion. So remember, for the drugs used for smoking cessation, NVB. Okay? NVB That is the drugs used for smoking cessation. Nicotine, very bad. NVP, nicotine, V for varenicline, B for bupropion. This I'm writing because don't get confused between buspirone and bupropion. Buspirone is an anti-anxiety drug. Bupropion is a drug which is used in management. It is an antidepressant which is used for management of this smoking cessation. So these are the drugs: bupropion, varenicline, and the nicotine. So it was asked one time, which is the most, let's say, the most efficacious or most effective. This is varenicline. Most effective drug is varenicline. Okay? And nicotine, we have a lot of this patches, lozenges, gums, etc. The fastest is nasal sprays. The fastest way is nasal sprays. We have a patch available, we already did, and the fastest is nasal sprays. Remember that. Okay. Now, a patient of cocaine overdose, which is not seen in the patient. Cocaine overdose, which is not seen in the patient. Very good. So cocaine overdose mein we don't see bradycardia. Why? Because cocaine, what is the role of cocaine? It is going to increase the levels of what? Increase the levels of noradrenaline or norepinephrine. So it is going to cause tachycardia rather than causing bradycardia. Remember. Okay? So cocaine overdose causes tachycardia. And this is very important, very frequently asked. This figure shows the effect of a drug on the dog's blood pressure. Okay. Now, can you tell me see this graph and which of the following agents is going to be responsible for this kind of graph? Epinephrine, norepinephrine, dopamine, isoprenaline. So mean blood pressures, always check two things. What is happening to the mean blood pressure? What is happening to the heart rate? So this drug is causing increase in the mean blood pressure, but it is causing reflex bradycardia. This is called as reflex bradycardia. Okay, so let us first do this graph and then we come back to this. You will be easily able to answer this. So this is a graph which is seen for three drugs, which is norepinephrine, epinephrine, and isoproterenol or isoprenaline. You know, epinephrine acts on all the alpha receptors, alpha 1, alpha 2, beta 1, also some amount of beta 3, but it has no beta 2 action. So what it does, it increases the systolic blood pressure by acting on the beta 1. In the blood vessel, only action on alpha 1. So there is vasoconstriction, increase in the diastolic blood pressure. So mean BPV is going to be high. Always remember the heart rate, your reflex heart rate, it will be opposite to that of the diastolic blood pressure. So if the diastolic blood pressure is high, the reflex action would be less. So it is going to cause reflex bradycardia. So this is caused by epinephrine. Opposite to diastole. If diastole is high, the heart rate would be low. So this is causing reflex bradycardia. Remember this, see in the graph. Epinephrine has effect on all the receptors. A for adrenaline, epinephrine, A for all. So by acting on the beta 1, it is causing increase in SVP. It acts on both beta 2 and alpha 1, but this action seems to be predominant here. So there is a fall in this. Mean will rise, but to little bit as compared to this one. Now again, this is falling. Okay? I said only look at the diastolic. If diastolic is falling, then the reflex action on the heart is going to be the opposite. So there is reflex tachycardia. Now, isoproterenol or isoprenaline, they only act on beta receptors. With beta 1, there is increase. Beta 2, there is decrease. The mean is going to be falling because beta 2 action is predominant here. And the more it falls diastolic, the higher reflex tachycardia is going to be there. It has got maximum increase in the reflex or the heart rate. So maximum increase in the heart rate is caused by isoproterenol, and reflex bradycardia is caused by norepinephrine. So here, if you see the graph again, there is reflex bradycardia and there is increase in the diastolic and mean. So remember, out of three, which was causing the reflex bradycardia? Norepinephrine. So the correct answer here is norepinephrine. Okay. Next one. Brief, you want to explain again? Okay. See, the thing here is you have to see the actions. Norepinephrine, epinephrine, and isoproterenol or isoprenaline. Norepinephrine acts on the blood pressures depend on two things, heart or blood vessel. In heart, may predominantly we have beta 1 receptors, which is going to increase the cardiac output, increase the systolic blood pressure. While in the blood vessels, we have two receptors, beta 2 and alpha 1. Alpha 1 causes vasoconstriction, increase in the BP. Beta 2 causes vasodilatation, decrease in the BP. And this is what we're talking about, the diastolic blood pressure. And beta 1 increases the systolic blood pressure. So norepinephrine doesn't have any effect on the beta 2 receptors. So beta 1 pe all are acting, whether it is norepinephrine, epinephrine, isoprenaline, all of them are going to stimulate beta 1 causing increase in the cardiac output. Ultimately, there is going to be increase in the systolic blood pressure. That is point number 1. Point number 2 is difference in the diastolic. Now, diastolic will depend on the action, whether it is predominant alpha action or beta action. Norepinephrine has no beta 2 effect. So the only receptor left is alpha 1. It will stimulate alpha 1. It will cause vasoconstriction, increases the systolic blood pressure. So here you will see there is increase in the systolic blood pressure. So when you take the mean of diastolic systolic, ultimately the BP is going to be high only with norepinephrine. It's a pressor agent. It's going to be high. Now the second factor you have to see is the heart rate. No, this is the reflex heart rate. Reflex heart rate is always dependent on your diastolic blood pressure. If your diastolic blood pressure is falling, the heart will sensitive, the baroreceptors are going to see that there is fall in the BP, then the baroreceptor is going to be stimulated, your sympathetic stimulation is going to come into picture and all that. Okay, so that is your reflex activity. But if your BP is already high, so I say diastolic opposite should be the reflex action on the heart. So remember this, here diastolic action is more. So there will not be any tachycardia, there will be reflex bradycardia. So bradycardia, this depends on the diastolic. If the diastolic is high, the reflex heart rate is going to be less. If diastolic is low, the reflex heart rate is going to increase. That is tachycardia. So here what you have to see only the effect on the diastolic. Or diastolic mein, there are two receptors, beta 2, alpha 1. So norepinephrine only action on alpha 1. Epinephrine action on both beta and alpha. But predominantly beta 2 is more visible here. So there is a fall in the BP. But agar hum mean nikalenge, this is much higher as compared to this. So ultimately there is a slight increase in the BP. Isoprenaline has no effect on the alpha, only effect on the beta 2 and the beta 1. Beta 1 was already there. Beta 2, there is fall in the blood pressure because it is vasodilatory. So as I said, now you have to look at the reflex tachycardia or reflex heart rates. Falling here, so it is going to be tachycardia. So here there is tachycardia, here there is tachycardia. But because the fall is much, much more here, the tachycardia is much, much higher here. So this is what you have to see when you get this kind of graph. See the effect on differentiating would be confusion will be between norepinephrine and epinephrine. There's a lot of things. Bradycardia, remember, only in norepinephrine. No bradycardia in epinephrine or iso. So make apna udari, the answer can be, you can make out. So wherever there is bradycardia, there is norepinephrine in picture. And when it is tachycardia, then you see which is going a higher tachycardia because that will be by isoprenaline. This is going to be one of the graphs they'll give. They'll give you one of the graphs. Either they give you for norepinephrine, epinephrine, or isoprenaline. Okay. All right. Now this one is this is something which you have to remember. The dose of adrenaline for penicillin hypersensitivity or anaphylaxis. What is the route and dose? You have to remember. Which of them is the drug of choice? First line conceal. Please make sure that the route is important as well as the dose, as well as the concentration. All these things are important. Nandini, very good. Very good, Nandini. It is number 3. 0.5 ml, 1:1000 IM. And what if you have to give the same thing IV? What will you do? Then you will further dilute this. It becomes 1:10,000. If you give the same dose IM, if you give 1:1000 as IV, it is going to go into the heart, cause tachycardia. Patient will die of arrhythmias only. So whenever you have to give it IV, you have to further dilute the drug. So IV mein hamesha it is less concentrated. Similarly, on this thing, if you have to match, which is the appropriate dilution for what use? 1:1000, it is for anaphylactic shock. 1:10,000, you give in case of cardiac arrest. Okay. Also, you give for epistaxis, bleeding through the nose. You can have compresses, and you will put those compresses in this 1:10,000 and press against the nose. 1:2 lakhs to 1:80,000, it is when you give it along with a local anesthetic as a vasoconstrictor. So these are important dilutions you have to remember for adrenaline. Then adrenaline. So this is the uses of adrenaline. A, B, C, D, E. A stands for anaphylactic shock. B stands for bronchial asthma. We don't give it as such now, but still you can. Adrenaline is only given in case of brittle asthma. You remember, drug of choice of brittle asthma, not for the others. Then C stands for cardiac arrest, right? And D stands for duration, prolonged of local anesthetics. And E stands for epistaxis. So these are the important uses of adrenaline. And this graph I've shown you, if they ask you what is the graph which is important, what is A? This is epinephrine and this is norepinephrine. So this is the same thing. This is your BP and this is your heart rate. The graph I had shown you previously, if this is shown, again, this means the reflex. The reflex bradycardia is there and there is high blood pressure. What I want to here focus on, they won't ask you in this about norepinephrine. They will specifically ask you here about adrenaline. And what is this here? This is called as a biphasic response. That they will ask you. If this graph is shown, that means they're asking you biphasic response. And biphasic response, how does it occur? With what drug does it occur? This occurs with high dose of adrenaline. Not low dose, high dose of adrenaline. Because when you are giving high dose of adrenaline, there will be a spike because of the alpha-1 receptors. And then it come back here and then go down. And this is only beta-2 receptors. The reason being alpha-1 action. Beta-2 receptors are more sensitive. So they can even function at lower doses. Beta-1 more receptors, what they happen? They're more specific or they're stronger receptors and they need higher dose. So higher dose may alpha-1 action predominant, lower dose only beta-2. So adrenaline, this is a biphasic response with high dose. This question hai, only seen with not low dose, high dose. Then the second graph, they will show you, they're asking you about the vasomotor reversal of Dale. So this is biphasic. Then they have given a alpha blocker, phentolamine. Then they have repeated epinephrine. Now only fall in BP is seen. There is no rise in BP. What is this phenomena called? This is called as vasomotor reversal of Dale, which is seen when you give alpha blocker and then give again epinephrine. So there will be only fall in BP seen because alpha receptors are blocked. So no rise in blood pressure is visible here. So these two graphs ka, this is the significance. These are the questions which are asked from this kind of graph. Okay. All right. Which of the following is not an adverse effect of ritodrine or salbutamol? So basically, we are talking about beta agonists here. What is not an adverse effect of beta-2 agonists? Very good, Himani. It is hypoglycemia. Okay? So beta-2 agonists, we don't have any. I think it's a similar question repeated. Let's do here. So let's see what are the side effects with beta-2 agonists. So remember, there are 3 T's and 3 H. Side effects of beta agonist. 1 T is tremors. Yes, tremors because of action on the beta-2, and this is the most common side effect. Most common side effect of beta agonists or beta-2 agonists, this is the tremors. T stands for tachycardia, especially if you give a higher dose, right? There are some receptors of beta-2 which are present on the heart. Predominantly, it's beta-1 only. But when you give high dose, then the selectivity is lost. They will also act on the beta-1. Then the third one is tolerance. H stands for hypokalemia. So they will push potassium inside. ठीक है, hypokalemia. Then another H stands for hyperglycemia. And the last one is hypotension. So these are the classical side effects which seen with beta 2 agonists. All right. This one, all of you must be knowing. Quickly, let's do this. What is the renal dose of dopamine? Okay? So renal dose, in the table here I have shown you that if you know the receptor on the renal blood vessels, then you can answer this question easily. Renal dose of dopamine. So first we'll do the table and then you can come to the answer. So remember DABA, D-B-A, effect of dopamine. D stands for effect on dopamine receptors, B stands for effect on the beta-1 receptors, A stands for effect on the alpha-1 receptors. So up to 2 micrograms, it only affects the D1 receptors, and in the renal, agar B1 receptors are affected, that will cause vasodilatation, renal vasodilatation. If you go slightly higher, then beta-1 receptors in the heart are also stimulated. So what is it going to do? It is going to stimulate the heart. It is going to increase the heart rate, force of contraction, everything. And this is how it is helpful in cases of congestive heart failures. If you go higher, then alpha-1 receptors are stimulated. Alpha-1 receptors, they cause vasoconstriction, causing increase in the blood pressure. So this effect is usually required if there is a patient of shock with a falling BP. Otherwise, for congestive heart failure and everything, you don't go beyond this dose. You do not want vasoconstriction in those patients. Okay? So remember, so now here the question, renal dose of dopamine is only up to 1 to 2 micrograms per kg per minute. Okay? It is not more than that. So then drug of choice. So dopamine is a drug of choice where it is a drug of choice in cardiogenic shock or septic shock. It is a drug of choice here. Okay. Excellent. Now, so as I asked you, we discussed the same thing. Now you can tell me dopamine in acute CHF does not act on which of the following receptors? As I said, this receptor is not required for action during CHF. We don't want this action during CHF. Which receptor? It is the very good. It is the alpha receptors because it is causing vasoconstriction that is not good for us for CHF patients. Okay, next one. 60-year-old male patient with frequent urination hesitancy, serum PSA levels, residual urines itna. So you know it's a patient of benign hypertrophy of prostate. So most appropriate initial treatment for this patient. What do you think? What do you start in this patient? What do you start in this kind of patient? We start with a drug that is, no, prazosin is not used in BHPs. We have a more specific alpha blockers. Prazosin actually also works on blood vessels. It will cause hypotension also. So yahan pe we would like an action which is specific to, yes. So the answer is tamsulosin because tamsulosin is more specific for the urinary tract, right? So see this diagram. This is very, very important diagram. So what are the drugs which act on the bladder and we are going to talk about here. So if you first go to the third one, alpha-1 receptors. So the alpha-1 receptors, they are present here in the trigone. And what happens in the patients of benign hypertrophy when there is a overgrowth of prostate around, they are going to restrict the flow of the bladder. So patient is going to have frequency, urgency, everything. So that is known as a dynamic component. Patient will come to you with urgency, bar he has to go to the washroom and frequency is there and all. So you want to relieve those symptoms immediately. And for that, you give alpha-1 receptor blockers. So we have tamsulosin, so these are the drugs of choice. Currently, the drug of choice as alpha blockers for this BHP is tamsulosin or silodosin, right? Now, the second component is the size of the prostate. You want to decrease the size of prostate. To decrease the size of the prostate, we have drugs which are 5-alpha reductase inhibitors. So these are your drugs like finasteride. So they are going to decrease the size, but they have a lag. They take about few months to, for the action to come. Immediate relief they will not give. So for immediate relief, you have to give these drugs. So what are the other drugs that we have? We have drugs like muscarinic. We have done antagonists, which are the formula is 5 dots. Overactive bladder ke liye 5 dots. And 5 dots, what do you mean by 5 dots? We have drugs like flevoxate. We have drugs like oxybutinin. We have drugs like tolterodine. We have drugs like solifenacin. D we missed. We have a drug which is darifenacin. Okay. 5 dots. And these are used for overactive bladder. Then we have detrosum muscles on which we have beta-2 receptors. So beta-2, the agonists which we have ritodrine, isoxpurin. So we just did the role of beta-2 agonists. So they're going to cause a relaxation. Then we have beta-3 receptors also present, which is now mirabegron, newer drugs, mirabegron and vibegron, which is also used in these conditions. So remember all these drugs, they are asked. This is a question, mirabegron, B3 receptor agonist. This is a question, M3. The question on BHPs, very, very important questions. Okay? So the difference is between prazosin and tamsulosin is only one. That jo prazosin hai, it acts on alpha 1A as well as alpha 1B. Alpha 1B is present in the blood vessels also, and it will cause postural hypotension. Therefore, we don't prefer this. Now, jo tamsulosin, they are specifically for alpha 1A because they are present in this area of the bladder and the prostate area. So they are specifically now this. So there will be no postural hypertension because of that. That is the advantage. Now, prazosin is a drug of choice. In case there's a patient of benign hypertrophy of prostate and he has hypertension also, then you will give prazosin. Okay? And the major problem why you don't give, usko hum kehte hain postural hypotension, also called as the first dose effect with prazosin. That is important here. All right. Glaucoma. Another important topic is glaucoma. Which of the following anti-glaucoma can cause heterochroma iritis? Very, very, very important glaucoma topic. Pigmentation of the iris, heterochroma iritis, which can cause. Very good. Letanoprost, Kursimran. So all the very good, Tarek Himani. It is the prostaglandin analogs. They are the drugs which can cause the pigmentation of the iris. So these are the drugs. So for the glaucoma, what you should know, you should be knowing the mechanism and you have to know the ADRs. Both are asked. Okay, so which drug acts by which mechanism, that is also asked. And what is the adverse effect, that is also asked. So everything is important. So jo prostaglandin F2 analogs should know that this is the drug of choice currently for open angle glaucoma. Okay, and they cause increase in the uveoscleral outflow. Prosts are going to increase the uveoscleral outflow, and their major side effects is heterochroma iritis, and they cause growth of, so this is, if you see here, this is the heterochromas iritis here. This one, this picture here is heterochroma, brownish pigmentation of the iris. And the second side effect, you see, this is the growth of the eyelashes. So this is also called as hypertrichosis. So the question usually asks is, they show you this picture, which of the following drugs has resulted in this particular condition? So this is the growth of eyelashes, or also called as hypertrichosis, and that is caused by prostaglandin analogs. The third one, which is important here, is macular edema. Three important adverse effects. Another thing to remember, if the glaucoma patient has already some infection like uveitis, hydrocyclate, which of the drug is contraindicated, you do not give these prosts here because they will further aggravate the infection. So do not give them if there is an infection. Then we come to these miotics, pilocarpine, physostigmine, and the new drug or relatively new drug, which is a nitarsodil, that is your Rho kinase inhibitor. Okay, so both of them are going to increase the trabecular outflow through the trabecular meshwork. Important side effects to remember. For the first two, they can cause broache, they can cause follicular conjunctivitis. And this one, nitarsodil, it is responsible for causing conjunctival hyperemia. Redness. Coming to the drugs which decrease the aqueous formation, A, B, C, D drugs. A for anhydrase, carbonic anhydrase inhibitors, like all those acetazolamide, okay, all those drugs. So they are going to cause corneal edema. Then we have apraclonidine, brimonidine, right? What they're going to cause? They're going to cause lid retractions. Lid retraction, apnea in newborn. So they are contraindicated in children less than 2 years. Another very, very important or commonly asked side effect. Beta blockers. Beta blockers, they are not given contraindication in cases of asthma. So if there is a case given asthma along with glaucoma, do not use beta blockers. But there is two drugs are here, timolol, bitoxolol. Timolol is a non-selective, bitoxolol is an alpha-1 selective blocker. So out of this, if you have to choose, you will choose an alpha-1 selective, which is bitoxolol and not timolol. So major side effects. So asthma or CHF, anything which is acute in nature, we are going to avoid these drugs. Then dipivefrin, which gets converted into epinephrine, prodrug. So it causes also conjunctival pigmentation. An osmotic diuretic that you can use is mannitol. So osmotic diuretics mainly you are using it in case of narrow angle glaucoma. Okay, ये conjunctival hyperemia. This is hyperemia. If case picture is shown. So this is a very one important slide where all the anti-glaucoma drugs can be revised from. This is just a slide if you want to it is not very oftenly asked. So what is active mydriasis? What is passive mydriasis? So active mydriasis is because of stimulation of alpha-1 receptors, and passive mydriasis is because of blocking of the M3 receptors. Just remember this. Okay, that is a slide for this. Okay, obesity may only you should know what are the drugs. Details are not very desirable here. So what are the drugs which has recently been approved for obesity along with phentermine? So phentermine in combination with what has been approved? Currently, the drug we have is topiramate. Topiramate is an anti-epileptic drug, but also it has been found to helpful in weight loss. So therefore, it is approved with obesity, for obesity as such. So these are your drugs which are meant for obesity or used in obesity. You may or may not know the mechanism. Hardly they're asking you, but in case you want, these are the drugs which causes lipase inhibition. So they decrease the absorption of the fatty acids. Phentermine and topiramate. So one is a norepinephrine agonist. Okay, the other one is a action on the GABA receptors, GABA agonist, you can say. So this is topiramate is used in epilepsy. Naltrexone, bupropion, you know that this is a opioid antagonist. And bupropion, it is working, Avidas is an antidepressant. So all these liraglutide, semaglutide, so these are used in diabetes. So they are all GLP-1 analogs. ठीक है, इस पे क्वेश्चन आता है कि which is the anti-diabetic which has a GLP-1 analog effect and it is also approved for use in obesity. This is the one. Then setmelanotide, there's a different receptor which is MC4R. MC4R agonist. And tirzepatide, but there was a question which is a dual GLP as well a GIP agonist. Okay, which is used in case of obesity. So the ones which have marked with Q are the important questions which have been asked. Now, which of the following is a false statement? False statement regarding the beta blockers, which is not true. So I will help you here. So see here, esmolol, the first one. It is a fastest acting, shortest acting beta blocker, right? Why? Because it is metabolized by plasma esterases. So any drug which is metabolized by plasma esterases will be a short acting drug. So which are the other drugs which can be asked, which are metabolized by plasma esterases? So one example we have done is esmolol. Other example of the drug is succinylcholine. Then we have Remi, fentanyl. Then we have adenosine. And then we have procaine. So all these are examples that are short-acting drug, esterases, because anything which is metabolized in the blood automatically becomes very short-acting. So now this question, patient has, so read asthma, hypertension. So which of the following drugs you can give to these patients without exacerbating, means without worsening the asthma symptoms? So here probably you have to find the best out of the lot. Ideally, if we have any other drug groups available, we prefer not to give beta blockers. But now there is a choice which one you should give. So you have to select a beta blocker which is cardioselective. All are non-selective except here. So which one is the one non-selective hai sare? Which one is the only cardioselective beta blocker here, which is your ethanol? Yes. So this becomes your answer. We don't give non-selective, atenolol becomes your answer here. Now there is a patient who has his hypertension as well as angina and he is on beta blocker. So any other comorbid conditions that he has, the doctor is asking him, but let's say he says that there's one more condition. So which condition is a contraindication to the use of beta blocker? Because he's already being prescribed beta blockers. So out of these, which condition do you think is a contraindication to the use of a beta blocker? Because it is not mentioned, it is a cardioselective, non-selective. So assume is any beta blocker. So out of this, where, let's say one of the conditions patient has, where you would not like to use a beta blocker. So here, cold extremities, because beta blocker, they will worsen the peripheral vascular disease, like Raynaud's disease, if you say Raynaud's disease. So this can be worsened. So you should not give beta blockers to a patient who already has a Raynaud's disease. Similarly, a patient was on metoprolol therapy, BP was not controlled, so verapamil was added on. So now this is a drug interaction between metoprolol and verapamil. So what do you think has occurred here? Very good. It is AV block. AV block has led to, both of them are cardiac depressants. So do not give these two drugs together. You can give the dihydropyridines, but you cannot give verapamil or even diltiazem. So contraindications of beta blockers, remember asthma, ठीक है, AV block or bradycardia, mainly. Then you remember acute CHF, right? Remember acute CHF. And then peripheral vascular diseases, you're not supposed to be given. Variant angina, and cautious use in patient of type 2 diabetes mellitus because it masks the symptoms of hypoglycemia. Now, the question is, यहाँ पे there are straight questions here. Which of them has a ISA or no? So remember these mnemonics. That is, contains partial agonistic activity. So we'll fill these charts. Celiprolol, ठीक है? Pindolol, then alpranolol and acebutolol. So beta blocker with antiarrhythmic activity or MSA possesses membrane stabilizing local anesthetic property. This is how you remember. P is propranolol, M is metoprolol, L is labetalol, ठीक है? A is acebutolol and another P is pindolol. Okay. Then cardioselective beta blockers. Mnemonic is mean cab. Okay, so remember mean cab here. Okay, I will see it. So M stands for metoprolol. So these you will see maximum being used in the cardiac cases, all the cardiac disorders. Metoprolol, esmolol, atenolol, right? Nebivolol. It also, N for nebi, N for nitric oxide, also releases nitric oxide, vasodilatory activity hai. So mean cab. C stands for carvedilol or, sorry, not celiprolol. A stands for acebutolol. ठीक है? And B stands for betaxolol, which is used in glaucoma, and bisoprolol. So this actually is a lot of mugging up. So these charts can be revised immediately 1 or 2 days before the exams. So just make sure you remember these mnemonics and then you can make out. Contraindicated in renal failure. So here the most important beta blockers I will tell you which is asked. So one is atenolol, which is asked here. It is contraindicated in cases of renal failure. B stands for betaxolol. C stands for celiprolol. Sotalol and nebivolol. Nebi is important to remember because it is also associated with nitric oxide production. Even nadolol is here and it is also has a vasodilatory effect. Okay? So longest acting beta blocker, it is nadolol. Nado, nadi or river means in Hindi means nadi. Nadi is very long. So longest acting is nadolol. Shortest acting we did esmolol. Plasma esterase. Alpha plus beta blocker. We have two. One is labetalol and the other is carvedilol. Carvedilol is also important because it also has antioxidant action. So therefore, it is used in various congestive heart failures and all. So same answer here. Carvedilol is a drug which also has a anti. So this chart, there are few charts which I would recommend that you just revise before you're going for 1 or 2 days before going to exam because you tend to forget this. There's nothing that, there's no rationale behind this, but remember these. So remember this one, also beta blockers. Okay, done? Sure. Now this is very, let's say very often asked. So I know everybody would be knowing the answer. This is a very, very cliched question. Time and again, child goes with his grandmother or somebody, cries profusely, has been bitten by something, And what is the major, the insect biting here? It is a case of scorpion bite. Yeah, so the drug of choice for scorpion bite is prazosin. Remember this. That is what is required here, drug of choice for scorpion. So this was asked recently also. So only just make sure that there is something like that. They will give you all these uh, cases, insect bite. Okay, alpha blockers, we are just told you, BPH, if it is asked with hypertension, then your drug of choice becomes prazosin. Scorpion sting, also prazosin. Pheochromocytoma, your drug of choice here is phenoxybenzamine, right? And then you can give a beta blocker later, but first you have to give alpha blocker, phenoxybenzamine. Cheese reaction, clonidine withdrawal, the drug of choice is phentolamine. Beta blockers, the drug of choice for migraine prophylaxis is propranolol. Thyroid storm, propranolol. Essential tremors, propranolol. Hypertension with migraine, again you give beta blockers like this. HOCM, here your drug of choice is metoprolol. But beta blockers, you can remember they are given. Aortic dissection emergency, esmolol. And glaucoma, timolol, betaxolol. Right? These are very important. Drugs of choice, ADHD, methyl phenidate, narcolepsy, modafinil, right? Tourette syndrome, which is asked, has been asked. Then what do you give for Tourette syndrome? Tetrabenazine. Acute CHF, dobutamine. As an inotropic, the drug of choice, inotropic drug of choice is dobutamine. Acute asthma, formoterol. It is a longer acting beta agonist, but its onset is quick and it is a longer acting. So currently the drug of choice along with inhalational corticosteroids. Urinary incontinence, we give Mira Begron or Vibegron. So these are some important drugs of choice from this particular chapter. Okay. Okay, so this we have finished now with the ANS part also. So before the next break, let's quickly do the CVS. Are you all in for that? Chale? Should we continue? Yes, very good. Okay. More yeses. Can I have more yeses? Or are you tired? Pharma is very vast. Can't help it. Okay. So we have to be there and yes, very good. Thank you. Continue. Okay. Now let's go on to the CVS and hypolipidemics I'll be doing together. So let's start with the first question. Which of the following drugs used in CHF does not decrease the risk of mortality on long-term use? Very good. Very good, Gursimran. It is milrinone. Milrinone is not a drug which will decrease the mortality. So you should know which drugs decrease mortality in CHF. This is very important. So this is a list of drugs decreasing mortality. Please know these drugs. Time and again, question has been asked, what are the drugs which are decreasing mortality? So long-acting or long-term combination of hydralazine with isosorbate dinitrate. Remember, if they're given alone, then they don't decrease mortality. The decrease has been seen only when they are combined together. Then ACE inhibitor. ACE inhibitors, ARBs or ARNI. Newer drug which is there. Okay? Angiotensin receptor, neprilysin inhibitor like sacubitril and all. They also have been shown to decrease mortality. Beta blockers, yes, they decrease the mortality. Spironolactones, yes, they decrease the mortality. So if you see that these three drugs, ACE inhibitors, beta blockers, spironolactone, they all act on the RAS, renin-angiotensin system. So all of them are going to basically ultimately are going to reduce the production of aldosterone. Aldosterone is known to cause ventricular remodeling in these patients. Okay? So they are going to cause ventricular remodeling in these patients. So then what you do is these drugs are going to stop that. So isliye they will prolong the lifespan of the person, decrease the mortality. Then currently, now this drug is so a group of so important because we will do doing this tomorrow also. 2 or 3 questions in latest INISET exam were from this group, SGLT2. And these are gliflozins. They are decreasing the sodium and glucose levels in the blood and they decrease the fluid load. So they are decreasing the sodium levels in the body. Therefore, they are improving the patient's condition who are on who are suffering with CHF. And because they are decreasing the glucose levels in the body, they are helpful in case of diabetes. So the latest drugs which anti-diabetic drugs has been found to be useful in CHF, these are your SGLT2 inhibitors. So these are your drugs which are going to decrease the mortality. And now what are the other drugs which can use acute heart failure? Very quickly, the drug of choice. If the patient comes immediately, you have to decrease the volume in the pulmonary edema ke saath the patient is there. You have to decrease that pulmonary edema by removing the excess fluid from the body. So what you give furosemide IV loop diuretic. So what they do? They decrease pulmonary edema. Nitroglycerin, sodium nitroprusside. Again, they are going to decrease the preload. Mainly the preload, but they also decrease the afterload on the heart. That is how they are going to be effective. Dobutamine, I told you, positive inotropic action. So this is the drug of choice, which is the drug of choice which can be used for its positive inotropic effect. This is dobutamine. Okay. Dopamine currently we don't use much because they have their own arrhythmic actions. It has a very high arrhythmogenic potential. So dobutamine is preferred. Milrinone. Milrinone kya hai? This is a phosphodiesterase 3 inhibitor. And this is going to increase the levels of cyclic AMP. In the heart, it increases the cyclic AMP and also in the vascular smooth muscles. Smooth muscles. So, in the heart, what it does is, it is going to cause increase in the heart rate and force of contraction, and in the vascular smooth muscle, it is going to cause a vasodilation. So, therefore, they are also called as inodilators. Ino means inotropic effect bhi hai. Dilatory effect means they also cause the vasodilatory effect. So, this is the reason for this. Levosimendan, which is a drug which is a calcium sensitizer. So definitely they are going to increase the contractions. Then nesiritide, which is a BNP analog. So BNP is basically what they do. They increase the cyclic GMP levels. Cyclic GMP levels in the vascular smooth muscles. So therefore they are going to cause dyspnea. They relieve the dyspnea. So they decrease the dyspnea in the heart. Right? So these are their beneficial effects of these drugs. So why are they used? This is their effect. ACE inhibitors or these, you know that they decrease the aldosterone level and they will decrease the vasoconstricting effect of the angiotensin 2. So aldosterone effect will be that they increase or they improve or what you can say the remodeling effects. And they enhance or prolong the survival of the patient, right? And adverse effects, very, very important, ACE inhibitors. Dry cough, not seen with ARBs. Remember which the differentiating feature? Dry cough, and the reason for dry cough is bradykinin. Angioedema. Again, this is a very dangerous ADR. So if it occurs, you have to stop giving the drug and you have to give antihistamines or corticosteroids here. Then they have hyperkalemia, allergy, dysgeusia, and also it is contraindicated in pregnancy, right? Beta blockers. Which are the beta blockers used? Bisoprolol, carvedilol, metoprolol, only these four are used. No other beta blocker is used in CHF, remember. So start with small dose, not to be given in acute failures, only to be given in compensated or chronic cases. Compensated heart failure, not for acute, because they are going to decrease the inotropic effect, and then that is not good. So what is they are going to decrease the heart rate and the energy requirement by the heart. That is how they're going to function. Spironolactone and all these, they are going to inhibit aldosterone, and you know aldosterone is responsible for remodeling. SGLT2 inhibitors, very, very important. Sodium decrease basically is going to be helpful in patients of congestive heart failure. Digoxin is very, very, very important drug. Though it is not much used, it is a drug used at a later level, but still a lot of questions are asked. So the reason why it is used, it is a inotropic drug. It is an inotropic drug, but still we are using this here. Other drugs, what can be used? So only remember the names of the other drugs which can be used. We have vasopressin receptor antagonist. Remember the two names, conivaptan, tolvaptan. So they can ask you, are they used? Yes, they are used. Conivaptan is IV, tolvaptan is oral. Arni, I told you, question aata hai, which is Arni? Arni is a combination of valsartan with sacubitril. Angiotensin receptor combination with neprilysin inhibitor. What is neprilysin? Neprilysin is a drug which causes the degradation of BNP. Okay? BNP was responsible for causing vasodilatory effect. But if it is metabolized, it won't be able to cause this effect. So you want to increase the level of BNP in the body by inhibiting the metabolism. So we inhibit this neprilysin and the drug is sacubitril. So this can be asked in the form of a picture. They can give you this BNP is released and it is getting metabolized by this drug, and यहाँ पे लिखेंगे metabolism, and here it is causing vasodilatory effect. Now, which is the drug acting at this site? Which is the drug inhibiting this step? And so your this step will be sacubitril, neprilysin inhibitor. Okay, so when you combine these two together, you form Arni, and this is another drug decreases the mortality. Then ivabradine, brad means bradycardia. So they only are useful in causing bradycardia. That is the role. So wherever beta blockers can't be given, you give this drug. They have no effect on the force of contraction, nothing else, only on the heart rate. Then these are some newer drugs. So newer drugs, they have a tendency, they can be asked, they may not be asked. Just remember the names. Myosin modulators, mavacamten, ovacamtiv. Okay, so this is just a new drug, nothing in detail. Now this question was asked last year, and this drug, sometimes they give you drugs that are totally obsolete. Nobody uses omopatrilat. Why? Because it is a neprilysin inhibitor and an ACE inhibitor. The problem with neprilysin inhibitor, one of the main side effects is angioedema. Similarly, problem with ACE inhibitor is also angioedema. So if you use them together, there'll be increased side effect. Okay, so जब side effect बढ़ जाता है इनसे, then you can't use them. ठीक है, so इसलिए these drugs are not to be used. No longer it is discontinued, but still, in case they ask you, you should know what this drug is. Okay. Patient on digoxin therapy was receiving several other drugs and he presented with flattening of T waves. The plasma digoxin levels were 3.8. Which of the drug could have caused it? Yes, tell me. Very good. It is clarithromycin. Clarithromycin is a P-glycoprotein inhibitor. And what it does, it inhibits the excretion of digoxin. Now, to solve this question, what you need to know is what is the range of digoxin. That's why I told you the range is important, because here you will not know if this range is toxic or not. If it's a low dose or a high dose. So therefore, the importance of knowing about the therapeutic index of such drugs, because when they give you this, you have the knowledge of medicine also, and then you can comment whether he's talking about toxicity or not. So here it is talking about toxicity with digoxin, right? So here, what you are supposed to know for this? What is the half-life? So once there was a question on the half-life of digoxin. So it is about 40 to 48 hours. So you roughly can write 40 hours. Now, what is more important is the level here I'm talking about. Levels of digoxin 0.5 to 1.4. Anything more than 2. If you see, read the levels, anything more than 2, this means the toxicity. So here the level was 3.8. That means it is a clear-cut case of digoxin toxicity. So when you're giving with the P-glycoprotein inhibitor, they inhibit the excretion of digoxin and they increase the levels. Most common cause of toxicity with digoxin is either you have given an overdose or there is some kidney disease. Most common and earliest symptom of digoxin toxicity. What is it? Nausea, vomiting, or GIT complaints, basically, anorexia. That is the earliest and most common. Most common arrhythmia, which is seen with digoxin toxicity, is your ventricular bigeminy. Vision defect seen with digoxin, yellow vision, or another name is xanthopsia. Digoxin toxicity can also cause or it can be also because of, it can cause hyperkalemia. Okay? Then what else can be there? Gynecomastia. If you remember the mnemonic of the drugs causing gynecomastia, these are your disco drugs. Digoxin, isoniazid, spironolactone, cimetidine, ketoconazole, omeprazole. All these drugs can cause gynecomastia. Remember, drugs causing gynecomastia, disco drugs. Now, how do you treat? This is equally important. Digoxin as such, there are 2 or 3 drugs which you have to know very, at the back of your hand, you have to know them. Digoxin, lithium, ACE inhibitors, they are very, very important drugs. Treatment of digoxin, now this thing. Ventricular arrhythmia, the treatment of choice is lignocaine. If there is an atrial arrhythmia, then you give a beta blocker. AV block, anywhere there is AV block, anywhere there is bradycardia, your drug always remains atropine. And we did in that table only that what is the antidote for this? That is digibind. Okay, so this is a very, very important table here. Toxicity trigger, what are the ions which can trigger? Hypokalemia, hypercalcemia, more commonly asked, and hypomagnesemia. Remember, digoxin kicks potassium, cuddles calcium. So if there is hyperkalemia, that will decrease the digoxin toxicity. If there is hypokalemia, it will increase the digoxin toxicity. And the opposite is for this. So remember, toxicity is more when there is hypercalcemia. Toxicity is more when there is hypopotassiemia. So remember, kicks, it doesn't like potassium. It has a competition with potassium, but it loves calcium because more calcium, more toxicity of digoxin. That you have to remember. Okay? Sure. So please know digoxin very well. Okay, now this one. 50-year-old male patient came to a local clinic with complaint of muscle weakness, tingling. So he has been on antihypertensive combination for about 2 weeks. There is a high level of potassium. So you see, the normal range should be between 3 to 5 of potassium. If anything is above that, so there is hyperkalemia. So now tell me which 2 drugs, when combined together, can cause hyperkalemia. Yes, which 2 drugs can cause hyperkalemia when combined together? So any drug which acts on the, remember, RAS system. Because ultimately, what is this renin-angiotensin going to do? It is going to increase aldosterone levels. And what is the role of aldosterone. Aldosterone leads to increase in the sodium retention and increase in the water retention, right? Now, sodium is staying in. Something has to go out. If nothing is free in this life. Okay? So, if sodium is staying in, potassium has to go out. So, this will lead to decreased potassium in the body. Hypokalemia. Now, if you want to inhibit this whole process, that means any system which is inhibiting the aldosterone ka action, it will cause hyperkalemia. So any drug acting on the RAS system, whether it is your beta blockers, whether it is your renin inhibitors, whether it is your ACE inhibitors, whether it is your aldosterone inhibitors, all of them are going to inhibit ultimately, or whether it is a spironolactone. So all ultimately, so that whole system is going to be inhibited. RAS system, aldosterone is going to be less. So less aldosterone means hyperkalemia. So from this choices, can you make out which two drugs are working on the RAS system? Yes, Tariq, very good. It is the choice number 1. Because this is an aldosterone inhibitor, this is also your ACE inhibitor. So all these, atenolol is a beta blocker, yes, but thiazide is a diuretic. It has no action on the RAS. Amlodipine, they are dihydropyridines, no effect on the RAS. So just make out which of the two drugs are acting on the RAS system. So they are ultimately going to cause hyperkalemia. And this is your answer to this very question. Okay. Now this is a question sometimes which they ask you about comorbid conditions. So it can be asked in medicine, it can be asked in pharma. So there is an overlapping. So which hypertensive antihypertensive which you like to give if there is a comorbid condition, another condition existing along with hypertension. The first option is if there is hypertension with migraine, beta blockers are preferred. If there is hypertension with end-stage renal disease, ACE inhibitors are better choice. In case of hypertension with gout, loop diuretics are useful. In hypertension with hyperaldosteronism, spironolactone is useful. Okay? So all are correct except for one. Which one you think is not a correct answer? So यहाँ पे you have to know which antihypertensive to be given in which kind of comorbid condition. Okay? Okay, let me first tell you which are the various antihypertensives given in certain conditions and then we can come back. So पहला सबसे पहला important, this is antihypertensive safe in pregnancy, right? So the drug of choice in hypertension pregnancy is your labetalol. You remember this. You can give hydralazine, okay? And you can give nifedipine, okay? And you can give methyl dopa. Okay. Now, this was a question asked once. Which potassium channel opener also causes decrease in the release of insulin? And it is the drug of choice in insulinoma. And the answer is diazoxide. Hypertensive emergencies may, that means where already there is some end organ damage. Now you have to give IV drugs there. The only remember which is the drug of choice here, that is nicardipine. Okay, this has been asked. Drug of choice in hypertensive emergencies. Urgency mein, abhi there is no damage to the end organ. So here you prefer the drug which is clonidine. Coming to comorbidities. ACE inhibitors should be given if there is hypertension along with any kind of kidney disease, chronic kidney disease, nephrotic syndrome, diabetic nephropathy, etc. ACE inhibitors are preferred over there. CCBs are preferred if there is a hypertension along with the Raynaud's disease, because CCBs are drugs of choice for Raynaud's disease. Okay, so if there is hypertension also, you give this drug. Prazosin, we just did alpha blocker hai, which is given if there is a BHP associated with hypertension. Beta blockers, in case there is migraine also. Okay, in case there is thyroid storm or thyrotoxicosis. right? If there is anxiety or if there is essential tremors. So here you prefer, but currently you know that the first line drugs may initially we had A, B, C, D. Alpha blockers, beta blockers, calcium channel blockers, and diuretics. But now the B has been removed. The beta is gone. Now only A, C, D is currently the first line drugs. We don't give beta. Only if there is these conditions, then only you give beta blockers. Otherwise, they're not no longer the first choice or the first line rather. Thiazides are given in case there is osteoporosis because it retains calcium. Nimodipine is a drug of choice in subarachnoid hemorrhage. Okay, this is a question. Spironolactone is used in case of resistant hypertension. And when do you call a hypertension resistant? If it is not responding to 3 drugs and one of the drug has to be a diuretic. This is the case with resistant hypertension. So comorbid conditions may, what another thing that you should know that here, if there is migraine, beta blockers are preferred. This is correct. If there is a renal disease, ACE inhibitors are preferred. It is correct. Another question in these two. Remember, spironolactone is an aldosterone antagonist. So, agar there is hyperaldosteronism, we will give spironolactone. Simple. So, this option is also correct. So, what is left now with you is this. And how you can explain this? Loop diuretics are more useful because abhi when we do diuretics, remember the side effects with loop diuretics. They increase the levels of 3 things: high glycemia, hyperlipidemia, and hyper or increase in the uric acid levels. So if there is increase in the uric acid levels, it is going to precipitate gout. So you cannot use them. It is rather contraindicated in gout. So this is your correct answer. Correct option. So the correct option remains this one. Okay. ठीक है? Side effects, agar hum baat kare, we already discussed the most important side effect here we're talking about is cough and angioedema. Cough ke liye you have to replace with a ARB. Most important side effect of CCBs which is asked is C for this and C for constipation and ankle edema. Thiazides, hypokalemia, hypercalcemia, and as I said, increase in the GLU, glycemia, lipidemia, uric acid levels. Beta blockers. Already we have done all the beta blocker side effects. You can put all those side effects here. Hydralazine, which is a vasodilator. It can cause reflex tachycardia, one of the major problems. Clonidine, very, very important. So many times asked, it can cause rebound hypertension. Methyl dopa, asked. Hemolytic anemia. And minoxidil, they can show you a picture with a lot of facial hair on that person. What drug is person taking? So they are causing hirsutism. Right? And because of this, it can be used or it is used in cases of alopecia. Finasteride, minoxidil, both can be used in the management of this alopecia. Male pattern baldness may use hote hain. Also alongside, what is more important here is pulmonary hypertension. Now, pulmonary hypertension pe, the question has been asked about nitric oxide inhalation. So nitric oxide inhalation is used in which condition? It is used in pulmonary hypertension because they are going to dilate. So which are the drugs, other drugs used in pulmonary hypertension? Phosphodiesterase inhibitor like sildenafil and tadalafil, soluble guanyl cyclase activator, Rio C. Guat. ठीक है, रियोसीगोट, सीगोट, guanylyl cyclase activator, रियोसीगोट. प्रोस्टासाइक्लिन्स जो यूज होते हैं, विच आर दीज, इपोप्रोस्टिनॉल. ओके, देन वी कैन यूज इलोप्रोस्ट. Prostacyclin receptor agonist. Selexipag. Drug of choice, pulmonary hypertension. Endothelin antagonist like bosentan. Bosentan. Okay, bosentan. En is endothelin and then it is the antagonist. Bosentan. Endothelin antagonist. Ambrisentan, bosentan. These are the drugs of choice. CCPs can also be used. Nifedipine. So the question has been asked on these ones. So pulmonary hypertension, make sure you know which drugs are used. Okay. Okay. Now RAS inhibitors we've already done. So this you need to fill in this only. Adverse effects humne kar liye. So all these like captopril. So you can fill in the adverse effects here. Captopril is a mnemonic. You can use cough, angioedema, proteinuria, taste disturbance. Okay. Orthostatic hypotension, प्रेगनेंसी में कॉन्ट्राइंडिकेशन, रीनल फेलियर. ठीक है, देन इंक्रीज इन द लेवल ऑफ पोटेशियम. L stands for low counts, or this one is granulocytopenia. So this is a RAS system. So I think last time FMG mein they gave you this RAS system and they ask you to mark. So there was a mark given here, which is the drug which acts here. Okay, which inhibits the angiotensin, which is the drug which will renin inhibitor, which is the drug which can act here, which is the drug which can act here. Okay, so here, so yahan se, because here they can have, like yahan pe we have beta 1 receptors. So there are drugs blocking the beta 1 receptors, beta blockers. Then there is renin inhibitors. Renin inhibits the conversion of angiotensinogen to angiotensin, like aliskiren, enalkiren, which is the drug which will block this enzyme, ACE inhibitors. Then what are the drugs like angiotensin? The receptors, which are the drugs which act on the receptors? They are your ARBs, which is the drug which blocks the aldosterone, spironolactone. So remember this by this way also. They give you a picture and asked you identify the target site. So ACE inhibitor, which is not a prodrug. So only the questions I've included which is important, which is not a prodrug. CL. CL is not a prodrug. That is captopril and lisinopril. Not prodrugs. Now ARBs, which can reverse insulin resistance. So which is the ARB which has been found to reverse insulin resistance? It is telmisartan, because it acts on the PPAR receptors. ARBs which can be used off-label in gout, that is losartan. Losartan का क्या काम? This is uricosuric. ठीक है, this is uricosuric drug. These are pictures which can be shown. Which of the drugs has done this? What is this? This is angioedema. ACE inhibitors, you will select from the options ACE inhibitors. Now this was shown in INICT last time. So which of the drugs has caused this on the ECG? So these are tall T waves and they show that there is increase in the potassium level in the body. So any drug out of the list which is causing hyperkalemia, I gave you a list, all the RAS drugs, they are going to cause hyperkalemia. So any option there, you mark that answer. Okay. All right. Now question on angina. Variant angina patients started on nitrates. What is the mechanism of action of nitrates in angina? So please remember, questions are asked, what is the mechanism in classical angina? What is the mechanism in variant angina? So here the question is on variant angina. The mechanism is different. Yes, very good. It is vasodilatory effect. Vasodilatation is the major cause or major usefulness in variant angina. So here you can write, it is coronary Vasodilatation. And what is the effect in classical angina basically? That is the decrease in the preload and the afterload. Maybe decrease in the preload, which will decrease the end diastolic volume. So, ये important है to know what effect is useful in which type of angina. Nitrates should not be combined with any drug which has a similar action. So, this is the action of nitrates, mechanism of nitrates. If you see here, they're increasing the cyclic GMP levels over here, right? Then they're causing the relaxation. So, they also cause the relaxation of the other blood vessels. So they are not to be combined with sildenafil. Sildenafil is that Viagra was there. Why patients died? Because some of the patient already were taking nitrates for their angina. And when they took sildenafil, what happened? There was catastrophe. So that's why the warning was issued that patient on sildenafil, either you have to see the patient shouldn't be a cardiac patient on nitrates. Most common side effect of nitrates that you will see because of vasodilatory effect is headache. Okay, there are others also. You can see reflex tachycardia. That is important. Then there is Monday's disease. Or what you call this is because of the tolerance to the effect. Nitrate tolerance. And the third one is methemoglobinemia. Okay, so it can cause methemoglobinemia. Now, this is important because, as I told you, Abhi, the question was asked on the cyanide poisoning. So, what you can give, you can citrates can be given, thiosulfate can be given in cyanide poisoning, and the other drug which can be given is hydroxycobalamin. Amyl nitrate inhalation also can be given for this particular treatment. So, longest acting nitrate is PETN, penta-erythritol tetranitrate. Shortest acting, amyl nitrite. Shortest acting is amyl nitrite. Okay, so drug of choice for acute attack of angina is this. Chronic prophylaxis में patches we can give, but acute attack of angina, you will give this. Now, if it is isosorbate dinitrate, 5 milligram sublingual, GTN 0.5 milligram. Dose is different in this. And what is the main mechanism? Vasodilator. See, in angina, drugs have only 3 types of actions. Either they are vasodilatory, or they cause bradycardia so that the workload on the heart is less, or they inhibit the fatty acid oxidation. So they will work by either of the 3 mechanisms. So let's find out which are the vasodilatory drugs. Nitrates are the vasodilatory drugs. Potassium channel openers are also the vasodilatory drugs. CCBs are also the vasodilatory drugs, right? Okay. Fasudil, which is a Rho kinase inhibitor. This is also a vasodilatory drug. Molsidomine is a nitric oxide donor, which is also a vasodilatory drug. Okay? Then there are drugs which can cause bradycardia and therefore they are effective in that. So one of them is beta blockers. Beta blockers, they are cardiac depressants. Cardiac depressants or they can cause bradycardia. Exertional prevent करते हैं. Ivabradine, brad है, so it will also cause bradycardia. And this is the side effect which is seen with ivabradine, that is the fuzzy vision. It is asked in exam. Then the third mechanism is fatty acid oxidation. So which drugs inhibit the fatty acid oxidation? This is your trimetazidine and ranolazine. They inhibit the fatty acid oxidation. So these are the 3 mechanisms by which these drugs work. Okay. So with ranolazine, one more action has been seen. Just that it also inhibits the sodium current, late sodium current. Otherwise, other action is fatty acid oxidation. So remember, तीनों actions में से one of the actions for management of angina. Okay. All right. So let's come to this. 82-year-old patient presented with acute episode of breathlessness, shows pulmonary edema, and now you have to treat pulmonary edema and is not taking medicine regularly. Out of these, which of the drugs can reduce the pulmonary edema? So any drug which is going to decrease the preload on the heart, okay? And they are going to cause, or they are going to be helpful in case of pulmonary edema. So here the option is nitroglycerine. Right? Nitroglycerine. So what are the drugs for pulmonary edema? The important drugs, the most important or helpful drug actually we have is loop diuretics, furosemide. Okay? Drug of choice, furosemide. We can use nitroglycerine. We can use BNP analog like nesiritide. And even morphine. It is used in left ventricular, whenever there is pulmonary edema, left ventricular failure, because it has a tendency to decrease the left ventricular filling pressure. So these are the 4 drugs which are helpful in pulmonary edema. All right. This is a slightly easy question. And isme you have to identify the class of antiarrhythmic drug. Okay. So what they have given you, they are telling you that it drug reduces the automaticity of the pacemaker. And you know which is the pacemaker in the heart? SA node. Okay, so they are telling you which drug reduces the action on the primarily on the SA node. Okay. CHF bhi hai usko, so patient must be on certain drugs for CHF also, and this drug also decreases the SA node. So which of the following? So class 1, class 2, class 3, class 4. So class 1 is sodium channel blockers. So class 2 is what? Beta blockers. Class 3 potassium. Class 4 calcium. So here the drug is class 2, your beta blockers. And which beta blocker is not a part of class 2 and it is a part of class 3? Only one drug here, that is sotalol. Remember, sotalol is not a part of class 2, it is a part of class 3 because class 3 action is more in sotalol as compared to the other drugs. Right? So ये एक table है, just remember, इसमें how the question are asked. The question can be in the form of a graph or this kind of picture given to you. Which of the following you have to identify which drug group is causing this, or they can simply ask you in the words as they've asked. So this is 1A. 1A drugs, they block the potassium channel. So they are going to increase the phase 3 depolarization wala. So this is how you will see prolonged repolarization. Class 1 के साथ भी यही action है and class 3 they have the similar action. So the similar graph, ठीक है, will be there. The only difference is if this is also there, sodium channel block is also there, then it is class 1A. But if there is no sodium channel block, only they are prolonged in the repolarization, then it is class 3 drugs. Class 2, they open the potassium channel, so there will be shortening of the repolarization. So this will be less. This is normal and this is less. And class 1C, they have no effect on the potassium channels. So therefore, it will be similar. This graph is going to be similar. So either the graph, so these 4 graphs are the most important which are asked, not of the others, only these. So you have to differentiate, especially between this and this, you can differentiate by the action on the phase 0. Differentiate that. Okay, what is another important is lignocaine. Lignocaine is the drug of choice, where for digitalis induced ventricular tachycardia. We also did in that chapter. So please note this one. Then beta blockers, except sotalol, they belong to class 2 drugs. No sotalol here. And they're used for tachycardias or cardiac arrhythmias, which is because of excess catecholamine in the body. So whether it is stress, thyroid levels are high, pheochromocytoma, you use them there. And in SVT. Amiodarone, very, very important drug here. Right? And all these drugs, which prolong the repolarization, they all can cause Torsades de Pointes. Very important question. And amiodarone is one of the longest acting out of these. So we are going to do amiodarone separately also because that is a very important drug to know. So I'll show you some pictures of that. So these are the side effects pulmonary fibrosis, thyroid dysfunction, blue man syndrome, corneal deposits, which is seen with amiodarone. Class 4 is calcium channel blockers. Class 5, all the drugs which couldn't be included in any of the class 4s, they have been put in class 5. So we have adenosine, which is the drug of choice for PSVT. Important. Magnesium sulfate, drug of choice for torsades de pointes. Digoxin is used in case of atrial fibrillations in CHF. Atropine, any kind of bradycardia, any kind of AV block, atropine is your go-to drug for that. Don't think twice before marking that. Now, okay, so quickly, what are the drugs of choice? Bradycardia and AV block. We are using atropine. PSVT, drug of choice is adenosine, right? SVT. SVT, we use 4 drugs, A, B, C, D. Remember, this was a question asked. There was a patient of SVT with asthma. So which of the drugs should not be given in those patients? So A stands for adenosine, B is a beta blocker, C is a calcium channel blocker, and D is digoxin. Agar asthma is also present, then you don't give adenosine, then you don't give beta blocker. Then your choice is CCBs. So remember, it was a question asked. Ventricular fibrillation. So amiodarone is a drug which you can give in any kind of arrhythmias except TDP. You can give it, it's a drug of choice for all. Usually it's given in any kind of ventricular or atrial, any kind, but we don't give it in TDPs. Agar it is specifically after digoxin, I told you the drug of choice is your lignocaine or lidocaine. Wolff-Parkinson-White syndrome, ablation is the treatment, but if it is not there, then you can give flecainide. Acquired TTP, that is because it has been due to some drugs, then the drug of choice is magnesium sulfate. If it is from the birth defect hai koi, then magnesium sulfate doesn't work. Then here the drug of choice is propranolol. Any kind of catecholamine induced, you have to use beta blockers. So this is the list, complete list of antiarrhythmics. Yahan pe question can be asked from any of this. Now, amiodarone is one thing which nobody should go to the exam hall without reading. This amiodarone, toxicity especially. So which of the following is not seen in amiodarone toxicity? Corneal deposit, hypothyroidism, hepatotoxicity, myocarditis. Not seen. Remember, nots are usually most often asked as compared to is seen. Yes. Idea? Kuch hai? Any idea? So, which is not seen is? Audio vision. 2. Nikhil says 2. Hypothyroidism. Okay. Hypothyroidism. 4 is myocarditis. Tarek. Okay. Very good. Okay. The correct answer is myocarditis. Hypothyroidism is seen with amiodarone. Okay. It is seen with amiodarone. So what are the main toxicity features with amiodarone? Remember, TPLC, फिर 1, 2, 2, 2. 1T, 1, 2, 2, 2. TPLC याद रखो. TPLC and 1T. 1T is only one with this. Thyroid dysfunction. Hypothyroidism is more common as compared to hypothyroidism देखा जाता है. So this is there. P stands for pigmentation. And this is your blue man syndrome. This is the blue man syndrome. All right. Then there can be peripheral neuropathy. L. 1L is lung fibrosis. Other L is liver toxicity or hepatotoxicity. 2 C's. Corneal micro deposits, something like this. And it is a cardiac depressant, not infection nahi karta. It is a cardiac myodepressant. So this is not seen in case of these make though this is absolutely must know the toxicity. Okay. Yeah, it is more is hypothyroidism is more predominant. Yes, it can be seen, but hypo is more, both can be seen. Hypo is more predominant, Biswajit. Then this question again, it had come. What are the drugs causing pulmonary fibrosis? So remember, a mnemonic, BBC, ban, me. Bleomycin, busulfan. C stands for cyclophosphamide. B is bromocriptine. A is amiodarone. N is nitrofurantoin. And ME stands for methotrexate. So all these drugs, they can cause pulmonary fibrosis. The second question was asked, what is the treatment for pulmonary fibrosis? Two drugs only currently are there for pulmonary fibrosis. Pirfenidone and nintedanib. Only two drugs. Okay, so treatment for pulmonary fibrosis only two. And these are the drugs which can cause pulmonary fibrosis. Okay, so now we have hypolipidemics. Kare, continue or you want a break? It's been 2 hours. Tell me. Or should we finish hypolipidemics and then take a break? Let me know. Let me know. Majority will go with the majority. You want me to continue with this or we'll take a break and continue? As you say. Continue. Okay, Gufran says continue. What about the others? Finish. Okay, perfect. Let us finish hypolipidemics and then we'll finish with this topic and then we'll take a break. Excellent. All right. So a 30-year-old woman presents to her physician with some lab reports. Okay. Now what is there is she sees a elevated LDL cholesterol level. Okay. So what is the most appropriate choice for her? If there is hypercholesterolemia, it is a very simple question. You have to give the drug of choice for hypercholesterolemia. And what currently are given for hypocholesterolemia is, yes, atorvastatins are given. Right? Now, yes, statins are drug of choice for, yes, very good. All of you are correct, for hypercholesterolemia. But agar this question would have been changed to a 30-year-old pregnant woman, then your answer would be different. ठीक है? इसमें वो option नहीं है, but then your option would be, yes, what do you give? If it is a pregnant woman, then you give bile acid sequestrants because statins are not given. Yes, cholesterol like this. Then you know option, even if it is given this, let's say they would have replaced it with the cholesterol or other drugs, cholestyramine and all, then you would not choose atorvastatin. Agar pregnant hai, then you will choose bile acid raisins. ठीक है? In pregnancy. Identify the wrong match between the drug and its mechanism. Can you identify the wrong match? Four, okay. That's all. One answer only. You can. I said you can give wrong answers. No problem here. You are here to learn. Doesn't matter. Gursimran says 3. Very good. Okay. Any answer is welcome. No idea. That's what I'm saying. Just tukka lagao. Just take a guess. 3, 4. Okay. All right. 3. Very good. Okay. So the correct answer is 3. Okay. Correct answer is 3. Because Elirocumab is also a PCSK9 inhibitor. So yeah, quickly we are going to revise. I'll tell you the highlighted ones are the ones which are must know, which I've highlighted here. Everything is not important. This is just to give you a brief overview of all the drugs that we have. Okay, so statins are the drugs which, this is the mechanism that you should know, HMG, CoA reductase inhibitor, and they decrease the LDL levels. LDL levels decrease karte hain, that is you should know. So you will find that almost all of them, जो हम यहाँ पे drugs we are doing, they all almost are decreasing they are increasing the LDL receptors in some way or the other. So they are the drug of choice for hypercholesterolemia, but in pregnancy, they are contraindicated. So in pregnancy, we give bile acid raisins. Okay? Then another important thing for statins, they cause myopathy and they cause hyperglycemia. Okay? That is an important thing. This was once asked as a question. If it is your LDL levels are very high, let's say 200 or something, then what should be the treatment? And wahan pe dose was asked. So that is why I have included this. Okay? So if what dose to be given in what kind or what severity of hypercholesterolemia. Now they say if there is no coronary vascular disease and your LDL levels are less than 190, then patient is at a moderate risk. So you can give either of this, rosuvastatin 5 to 10, atorvastatin 10 to 20, right? But if there is a history of a coronary heart disease and this vascular disease, whether the LDL levels are 190 or more, you will start with a higher dose of these drugs. Rosuva 20/40, atorva 40/80. So remember like this. So we have rosuvastatin, atorvastatin. So agar low risk hai, so you give small dose. You give 5 to 10 and here you give 10 to 20. And if it is a high dose, you straight away what you do? Here you give 20 to 40 and here you give 40 to 80. So double this here, double this here. Okay, double this, that and double here. So this is once it was asked. If you can remember, very good. Nahi aata to you can always go. But this is important, cholesterolemia. And the pleiotropic effects are asked. Okay, which of them is a pleiotropic effect? So pleiotropic effect is when there is decrease in the oxidative stress, endothelial dysfunction, increase in the nitric oxide. All these are pleiotropic effects. Now, the question is important here. Maximum decrease in LDL is caused by which statin? Maximum decrease. It is called by rosuvastatin. Okay, Rose causes the maximum decrease in the cholesterol or this LDL levels, cholesterol levels. Prodrugs. Which are the prodrugs? Lovastatin and simvastatin. Lova and Sims are prodrugs. Which is the most potent? Pitavastatin. So these are all the questions here. So you can, I will highlight these also because they have been asked. The most potent prodrugs, maximum LDL cholesterol effect. And this has also been asked here. Right? Save statin here, if you come here, save statin in the liver disease, which is pravastatin. Because there is no CYP metabolism with this. Safe in kidney disease is atorvastatin. Now, the statins are supposed to be given at night because the maximum production of cholesterol occurs at night. But the longer acting statins do not need to be given at night. They can be given at any point of the day. So atorvastatin and all these drugs, they don't need any time restrictions. Okay? The next group, only remember that this is given in pregnancy when there is hypercholesterolemia and they can cause constipation. Fibrates, the action is on the PPAR receptors and they cause decrease in the triglyceride level. So therefore, they are the drug of choice for hypertriglyceridemia and they have been associated with gallstones. Myopathy is also common, especially if you combine fibrates and statins together, the risk of myopathy is more. Niacin is the drug which causes a maximum increase in the HDL and the only drug to cause decrease in the lipoprotein A. And the side effect is flushing because of prostaglandin release. So what you can give? Aspirin. Aspirin inhibits the COX enzyme, inhibits the prostaglandins. That is not. And now we have a specific prostaglandin antagonist, laropiprint. Okay, so this is a prostaglandin, PRANT, prostaglandin antagonist, laropiprint. Then ezetimibe is asked as such, which of the, जैसे हमने पूछा कि what is the mechanism? So it is a NPC1L1 inhibitor. NPC1 is Niemann-Pick C1 like 1. Don't remember the full form. It is Niemann-Pick C1 like 1. It is just like bile acids. It is going to help in the absorption of the cholesterol. So ezetimibe is going to decrease the absorption. Only remember the name and the mechanism, not anything else. Now this table, please know, now this has been asked up team number of times. PCSK9 inhibitor. So pro-protein convertase subtilisin kexin. आपको full form nobody is going to ask you. Only remember PCSK9. What is the role of PCSK9 otherwise? This is your liver and this is the LDL receptor in the liver. Now PCSK9, it will metabolize it. It will destroy this. Okay? It will take it in and it will destroy this. So when there is no LDL receptor, how do you think from the blood LDL will be taken up into the liver? So what this drug does is it will inhibit this destructor. So the one which is destroying the LDL receptor, it is going to inhibit this. So there will be more LDL receptors available. So more LDLs will be taken up. More LDL taken up in the liver, so there will be decrease in the LDL cholesterol in the blood. So that is the main mechanism. And these three drugs, please know these three drugs very, very well. Evirocumab, evolocumab, inclisiran. Tino drugs, PCSK has been asked many times. And then these are the other list of drugs. So only thing you have to know the names and the mechanism. Okay, so एक और table which you need to have a look before you go. And this question, which of the following has no effect on the LDL receptor? Please remember, this was one of the options given. It only is an antibody against a kind of enzyme which regulates the lipid metabolism. There's no effect on the LDL receptor. So this drug, no effect on the LDL receptor. This is important in this one. Okay. So this was the question that I told you. So here now you can answer. This was the same question I was telling you about. Which of the following hypolipidemics does not work by LDL action receptors? So ये तो है ही नहीं hypolipidemic. So they all, this PCSK9 has an effect on the LDL receptor. Gemfibrozil has an effect. So only this drug, it does not have any effect. So the correct option is evolocumab. All right. So with this, your hypolipidemics in brief, in short, they've also been covered. So what now we are left with is the respiratory, autocoids and blood. That will be finished in about 1 to 1.5 hours. So now it is 5:30 almost. Will a 15-minute break be okay for you? Is it okay? A 15-minute break? Yes. All right. Okay. And we meet at 5:45 then. All right. 5:45. So even if we go like till 7, I hope it is okay with all of you because I want to finish this and not leave it for tomorrow. Even if we go till 7, is it okay with everybody? Yes? All right. So 5:45, please make it a point to reach here. So we will pause here and then again restart at. Okay? All right. So see you all. Let me pause this one. Okay. Okay. All right. Okay, so let's start with the next topic, that is the respiratory system. Let's see what are the important things that you need to know in that. Okay, the question is, a 65-year-old male with a history of COPD is admitted to the hospital with the worsening of symptoms, has been on theophylline therapy for some time now. His heart rate is 110 and looks anxious. Also increase in the urine output. What is the likely explanation for this? Theophylline inhibits the renal prostaglandins causing diuresis. Or second is stimulates the renal tubule absorption, or it blocks the adenosine receptors in renal vasculature, or it blocks the phosphodiesterase to cause diuresis. So here basically they're telling you that these are the side effects of theophylline. Now you have to segregate which is because of phosphodiesterase inhibition and which is because of the adenosine antagonism. That is what is required and has been asked. This is what you should know. Very good, Simran. It is choice number 3. So third answer, that is, it blocks the adenosine receptor in the vasculature. Now, what are the things that you should know for theophylline? Another very, very important drug if we talk about from the examination point of view. Right? As I said, it has also a narrow range. So it has a tendency, or this is a candidate for therapeutic drug monitoring. Also, we did that this drug shows zero order kinetics. Okay? And it is metabolized and it can be induced as well it can be inhibited by the enzymes. So any induction inhibition you see to that they are because it is metabolized by the enzyme CYP1A2. Okay, so induction, inhibition, whatever reactions are because of this. Bronchodilatory effect mainly occurs with the help of phosphodiesterase inhibition, phosphodiesterase 3 as compared to phosphodiesterase 4. And another reason for bronchodilation is the adenosine antagonism A1. No, adenosine is a bronchoconstrictor. Any drug which inhibits this is a bronchodilator. So these are two mechanisms which are responsible for bronchodilation. Now there is also a mechanism which is responsible for this anti-inflammatory action. So what is that? It enhances the histone deacetylation. Just remember this line, histone deacetylation, and that is responsible for the anti-inflammatory effect. Okay? So aminophylline is a drug that we give by IV route. Theophylline oral route. There's no inhalation or inhalatory property which is available, or inhalatory dosage form which is available for these drugs. Now, side effects, whether it is because of phosphodiesterase inhibition or whether because of A1 inhibition, that is important. So, phosphodiesterase inhibition, PDE. P means for pet duct, that means stomach ache. So, all the features of, we say, nausea, vomiting, and this, diarrhea, gastric discomfort, it is all because of phosphodiesterase. Stands for Dimag. Okay. I will wait for 2 minutes. Let me wait for 2 minutes. Please confirm again if there is a voice break, or is it okay? Fine? Okay. Fine? Fine with everybody? Okay. Oh, I'm assuming that it is okay now. So I'm continuing. Okay. All right. Thank you, Nikhil. Thank you for Simran. Okay. So A1 inhibition, diuresis, and A1 inhibition also leads to seizures. And both of them, they can lead to arrhythmias. Right? So this is how they ask you, which is specifically because of phosphodiesterase inhibition, which is specifically because of adenosine antagonism, which can be because of both. So remember this, PDE, pet dard, then dimag mein dard, that is headache and nausea, vomiting. Then remember both can cause heart issues, and the rest of the two are with only A1, that is diuresis and seizures. Okay. Other drugs which can be used for bronchial asthma. What are the other drugs? What is the important points to know? We can use beta-2 agonists, that we know. The route can be oral, can be inhalational, can be subcutaneous, can be IV. Any of the drugs can be used. Non-specific beta agonist. Only remember one that we did initially was epinephrine. Epinephrine, it is used subcutaneously for brittle asthma. Remember, this is subcutaneously for brittle asthma. Specific drugs, which is your short-acting beta agonists. You have salbutamol and terbutaline. Terbutaline is also given by subcutaneous route. Okay, it is also given by subcutaneous route. Long-acting for prophylaxis. Now, there is solmetirol. So, metro trains are long. So, it is a long-acting. Solmetirol, which is also IV. And we have formoterol. So, metro is long. Metro trains are long. So, long-acting beta agonist. But remember, formoterol, what you have to remember? It is the drug of choice, I said, for acute attack. Why? Because it is long acting, but it is also the onset of action is also very quick. So it has the best qualities of both. It is acting fast and the action is lasting longer. So this drug can be used for acute attack, but salmeterol cannot be used for acute attack. It is only used for prophylaxis. Then question on the name, identify the very long acting beta agonist. Only the names are important. So we have indacterol. Has been asked, indacterol. Vilanterol. Clenbuterol. Okay. Now this drug is banned now because it also had anabolic action. So this is currently no longer used. But please remember these names only for your MCQ, identifying which drug is a very long-acting beta agonist. Adverse effects, I told you already. You can fill it from the previous one. T for tremors, most common, tachycardia, tolerance. Then it can cause hyperkalemia and, hypokalemia and hyperglycemia. So these are the repeat ones from the previous, but very important. Next is anticholinergics, which are going to be given by the inhalation route. So these are your drug of choice for COPD. COPD ke liye beta-2 agonists are not the drug of choice, only is your anticholinergics, because COPD, they have a high tone of cholinergic activity in them. So drug of choices for COPD is your anticholinergics. And yes, they can be given in cases of bronchial asthma. Bronchial asthma mein you can give only when if the patient is on beta blocker. patient is on beta blocker, beta receptors are blocked, there is no fun of giving beta 2 agonists. So here you can give anticholinergics in this case. So here also we have short acting drugs, short acting muscarinic antagonist. So which are these? Tiotropium, and ipratropium. If you have those PDFs, make sure that you are writing them because baad mein you won't get time. So this is the time to fill in those PDFs. Tiotropium, ipratropium. Which is the shortest acting out of these? Ipratropium. Shortest acting. Okay. Then we come to which is the long acting drugs. And the long acting where we have oxytropium, right? We have eclidinium. Then we have umeclidinium. So the clid wale, they are all your long acting drugs. Okay? So even glycopyrrolate has been currently recommended to be used here. So oxytropium, eclidinium, umeclidinium, in this question has been asked on these drugs, and glycopyrrolate. So out of these, the longest acting drug is eclidine. Okay, so this is the longest. Then this was the question asked in the INICT. Why is there a paradoxical bronchoconstriction seen with the patient on anticholinergics? So these are the reasons. If you are giving these drugs with a hypertonic saline, or you are giving them in a inhalation manner where you have, these chemicals are present, EDTA, benzalkonium. So they can also cause reflex, the bronchoconstriction can be triggered, or there is a presynaptic muscarinic block. Okay, so this can transiently cause this bronchoconstriction. So these are the three reasons which were given in that choice. So make sure that this is important. And here ipratropium causes this bronchoconstriction and not tiotropium, because tiotropium is very specific for M3. Ipratropium acts both on M3 and M1. And this is a presynaptic. So whenever you act on the presynaptic are autoreceptors. So what they will do, if they act on the presynaptic, block karenge, there will be release of acetylcholine. So initially, transiently, they will cause bronchoconstriction. But because tiotropium only works here, they don't have this initial bronchoconstriction. So remember this here. So these are some other drugs, leukotriene antagonists, which are used. These are your Leucast, Zafir Leucast. Okay, remember the names here. And Monte Leucast. They are not for acute attack. They are only given for prophylaxis, not for acute attack. And this is the question. What is the problem they can cause? Because they increase the leukotriene levels and they cause the Churg-Strauss syndrome. LOX inhibitors, which inhibits the enzyme lipoxygenase, therefore no leukotrienes are not formed. And these are the ones which act on the receptors. Okay? These leukotriene antagonists, they act on the receptors, while this inhibits the synthesis of leukotriene itself. So xylitol, but this is hepatotoxic, remember. Mast cell stabilizers, again, these are the drugs which only well work for prophylaxis, not for acute attack. Okay. Which of the antihistaminic drug has a mast cell stabilizing action? Antihistaminic with a mast cell stabilizing action. You have ketotifen and you have olopatadine. Okay? Antihistamine with a mast cell stabilizing action. Then steroids are used. Steroids can be used. Now inhalation steroids are the drug of choice. You start in the acute attack only, along with your formoterol. So current recommendations by the GINA guidelines are that once there is an acute attack of asthma, you start with formoterol and alongside you add inhalational corticosteroids. Do not wait because it is anti-inflammatory. It will help in these patients. Okay. All right. So then they are the, if you're giving them for a oral you give prednisolone. If it is not controlled by inhalation, then you give the oral drug. Okay. So steroids usually are the drug of choice for persistent cases. Mild cases may beta-2 agonists may be sufficient, but persistent cases, prophylaxis के लिए, persistent cases के लिए, chronic asthma के लिए, then they become your drug of choice. Okay. Inhalation में, inhalational corticosteroids. Which are the drugs that we use? We can use beclomethasone. We can use budesonide. You can use fluticasone, right? This is the most potent, right? Then you can use cyclesonide. And cyclesonide is also called as a soft steroid because it has a least side effect. Soft steroid, least side effect. Pro drug hai, it gets activated only in the bronchus, has least side effects. It is also called as the safest or the soft steroid. IV form of steroid is used in case of emergency, that is status asthmaticus only. ADRs, so patient who is inhaling this, so what you tell the patient, you rinse after that. Otherwise, the patient can land into oropharyngeal candidiasis. White, if they show you a picture, there'll be the tongue of that person that will be white. And what will it be because of? It will be because of taking the inhalation steroids and not gargling or cleaning properly. And if the patient develops oropharyngeal candidiasis, what you give, the drug of choice treatment is that you give nystatin. You can give nystatin or you can give clotrimazole. Okay, so you give these two drugs for this. Then these are some monoclonal antibodies. Tomorrow also at the end, I will provide you a list of monoclonal antibodies. That list you need to know. So all of them will be included there also. So those are some of the indications and that list. So you can keep that list with you for future revisions because these are the, you can't remember all the monoclonal antibodies. So I'm not expecting you, but those are few important monoclonal antibodies. Jitne bhi you can remember, try to remember. Nahi aate, that is also fine, but there are few which are very important. So that list already, at least if you do that, nothing else, you will be done for at least monoclonal antibodies from there. So omalizumab is used here. Then there are newer ones, benralizumab, reslizumab, and zumab, mepolizumab, all these things are there. So these are monoclonal antibodies useful in asthma. So if the question comes after you have done this, now can you answer which of the drugs is not used for acute attack of asthma? Formoterol, steroids, cromolyn sodium, yes. See, steroids, I told you that you start with this. So अगर आपको इसमें और इसमें question आता है, ठीक है, steroids are good. But I told you that acute attack में you start with the steroids along this. It is a drug of choice in prophylaxis, but currently acute में we start with this. So see this one, cromolyn sodium. Cromolyn sodium, what it does was, क्या करता है cromolyn? Mast cell stabilizer. So there is no role of mast cell stabilizers for acute attack. So you only give it for prophylaxis. Okay. Now, this is a phosphodiesterase inhibitor used in COPD. Which is the phosphodiesterase inhibitor used in COPD? The answer is roflumilast. And how it works is phosphodiesterase 4 inhibition. Okay, phosphodiesterase 4 inhibition. That is what is important. Phosphodiesterase 5 की अगर हम बात करें, sildenafil, tadalafil, all these drugs, they are used. ठीक है, phosphodiesterase 3 है, your milrinone and ambrinolone, in ambrinolone, silastazole, they are phosphodiesterase 3 inhibitors. Non-specific phosphodiesterase inhibitors, theophylline, ठीक है, so 3 पे भी काम करता है, 4 पे भी काम करता है, others also, ibudilast. So this one, roflumilast, is specifically for the COPD, acting on the phosphodiesterase 4 inhibitors, okay. Now, I wouldn't have included this otherwise, but because it came just recently in the exam, so there is a chance it might repeat in the NEET PG also. Drugs for cough. Okay, so there was the question there, it was like the patient has a thick tenacious sputum. So which of the following drugs will you use? So there your choice would become a mucolytic. So that's why I've included this question. So for cough, in case they're asking you, so you know which drugs are useful for cough. Okay, which of the following opioid can be used as an antitussive? Can you know out of this? Opioid, very good Nandini, it is codeine. Codeine is a antitussive agent. So yahan se what basically you should know, so here these are the opioids. They act on the cough center. They only suppress the cough. Where do you want to suppress the cough? A dry cough, irritating cough. Patient is getting unnecessarily disturbed. So only there you will suppress the cough center. If it is a productive cough, there is sputum coming out, infection hai, then you will not want to suppress the cough, because if you suppress the cough, the sputum is inside and the chances of infection spreading is higher. So there you will try to remove the cough by giving expectorant or mucolytic, etc. So drugs which are antitussive are your opioids, dextromethorphan, and some of these antihistamines. So you will find these combination present in the market preparations. Now, which are the drugs which was asked basically in this question? Which are the drugs which help in removing the sputum or making it thinner or breaking this, tenaciousness from there? So either you can have a mucolytic which breaks that sputum, bromhexine, ambroxol, or there are enhancers, secretion enhancers like guanifacin, ammonium chloride, and bronchodilator as such. They are going to help in the dilatation. So this was actually the question which was asked recently in INICT. So just make sure you go through this, because there are chances this type of question might be repeated, may or may not be, but then you know this topic, so make sure. Okay, next one, autocoids. So respiratory, I think this was more than enough. Autocoids may, let's go to the autocoids now. Now, this is not a strictly autocoid question, but let's see. Which of the following drug is used for pain relief in arthritis and acts by both opioid and non-opioid mechanism? Okay, so it is not, this drug is not strictly a NSAID, but it works by opioid as well as non-opioid mechanism. Yes, Tariq, very good. Nandini, very good. It is tramadol. Tramadol is an opioid and also it inhibits the reuptake. What is the role? Ketorolac is a NSAID. Okay, it doesn't have any, it is not a opioid as such. So inhibits the reuptake of 5-HT and noradrenaline. Also, it stimulates alpha-2 receptors. So it has multiple actions. So this is why they ask you, which is the other mechanism? One is opioid mechanism and this is the non-opioid mechanism. Inhibits the reuptake. So therefore, this is a question which is done. Now, NSAIDs ke baare mein, what is the important thing? You know that this is the mechanism, this is the COX enzyme, and your NSAIDs work here. Right? Your NSAIDs work here. So we just did leukotriene receptors pe. There was working of which one? Montelukast, zafilukast, they work here. And the lipooxygenase enzyme, this is inhibited by xylitol. And here, this is inhibited by corticosteroids. That's why corticosteroids are such a powerful anti-inflammatory drugs. Okay? So here we have the NSAIDs. They inhibit the cyclooxygenase pathway. So they inhibit the formation of prostaglandins that we know in thromboxane. Now let's come to the important questions. Non-selective COX inhibitors, they have more chance of GI toxicity. So let's talk about aspirin here. What is important to know about aspirin? That low dose aspirin Works as a anti-platelet drug. And what is the mechanism? Inhibits the thromboxane A2 synthesis. This is a question. How aspirin works as an antiplatelet drug? And another important thing, aspirin is a hit and run drug. What are hit and run drugs? Suicidal inhibitors भी कहते हैं, जो अभी it was asked in the exam. So hit and run drugs are those drugs which have an irreversible action. So it inhibits the COX irreversibly. Okay, this is important. Irreversible action. And what is the other important thing to know? Children, it causes Reye syndrome. In all children? No. Especially if the child has viral fever and you give aspirin to that child. So there will be Reye syndrome, hepatotoxicity, right? Number 5. Low dose agar aap aspirin is also, it causes increase in the uric acid levels. So aspirin is not given in cases of gout. Okay, so remember these things about aspirin. Then important is toxicity, salicylism, excess. So what it causes? First, there is respiratory alkalosis. Ultimately, there is metabolic acidosis. This is important. And because of this reason, it causes metabolic acidosis, which is irreversible. How do you treat overdose with aspirin? Again, it's a revision. Abhi humne kiya. How do you treat this? Very good. Bicarbonates, acidic drug, management with sodium bicarbonate. So you give sodium bicarbonate. Okay, antidote. Very good. Okay. Paracetamol, another important topic. Paracetamol. Acetaminophen is the other name. It has no anti-inflammatory. So which NSAIDs out of this, they ask you, which is the drug which has no anti-inflammatory action, which can't be given in any cases of inflammatory disorders like osteoarthritis, RA, etc. This is your paracetamol. And the action is via COX-3 inhibition in the central nervous system. Okay? Least risk of GIT, renal side effects as such. Most common cause of poisoning because of paracetamol is overdose with the drug, and especially if there's an alcoholic or there is a liver disease present already in the patient, because it is also going to cause hepatotoxicity. And what is that toxic metabolite which causes hepatotoxicity? NAPQI, N-acetyl para-benzoquinone, okay? NAPQI. And this NAPQI is hepatotoxic because it is no longer getting metabolized by glutathione. Glutathione otherwise metabolizes NAPQI and makes it into a less dangerous form. But because when there is overdose, this glutathione will get saturated and NAPQI is going to go here and there in the liver and cause damage. Then antidote, another important. So we have done already in the antidote list before that this is the antidote for paracetamol poisoning. What other important one-liners to know from this NSAIDs is indomethacin is a drug of choice in cases of acute gout and for causing PDA, patent ductus arteriosus closure. Because prostaglandins maintain the patency, so you have to inhibit prostaglandin. When the child is born, still there is patent ductus arteriosus, then indomethacin needs to be given. If no indomethacin, then the second choice is ibuprofen. But drug of choice is this. Ibuprofen is the only anti-inflammatory which is recommended in children. Recommended in children. Diclofenac, it is a COX to preferential drug. ठीक है? Pyroxicam, they are all very good anti-inflammatory drugs. It is a long-acting drug because it undergoes enterohepatic circulation. Ketorolac can be used IV. It is a very powerful analgesic, has equal, let's say, efficacy as compared to opioids. That powerful it is, ketorolac. Okay. Then coxips, these are selective COX-2 inhibitors. So they have less chance of ulcers. They are more cardiotoxic. Celecoxib, they are longer acting drugs. Parecoxib is used IV for post-op pain. Rofecoxib, valdecoxib, they have been banned. Why they have been banned? Because they caused myocardial infarction. Lumiracoxib, banned. Why? Because of hepatotoxicity. Okay. Okay, so that was over with NSAIDs. Now let's go to prostaglandins. Prostaglandin questions, is usually 1 and 2 is asked on the prostaglandins. So you only need to know the indications of prostaglandins, which drug is used in what indication. That's the only thing here which is important. So all are well-known indications of prostaglandins except cervical ripening, abortifacient, NSAID-induced peptic ulcer, or patent ductus arteriosus. Okay, Nandini says 3. All right. What about the others? 3. Okay. Okay. Tariq says 3. 3. So all of you are saying 3. Now see, read this question. NSAID-induced peptic ulcer. Treatment of choice or drug of choice? What is it? What is it? NSAID-induced specific ulcer. What is the treatment of choice? Himani? Very good. Himani is correct. MISS? No. Treatment of choice, drug of choice. We have PPIs, omeprazole group of drugs. But the specific drug for NSAID-induced ulcer is misoprostol. Yeah. Specific hai misoprostol, but drug of choice is PPIs. So this is also an indication. PDA, ductus arteriosus. Okay? Ductus arteriosus की patency, if you have to maintain it, you need prostaglandins to keep it patent. Okay? But what do you understand by the term patent? Patent means that this ductus arteriosus is still there even after the child is being born. So that is called as still opened ductus arteriosus, and you have to close it. For opening, it is important, but if you want to close this, then you use NSAIDs. As I told you, indomethacin, ibuprofen. So this is not an indication for prostaglandins. Okay? The indication for use of prostaglandin is not PDA. Okay? It is responsible for opening, keeping the ductus arteriosus open during when the child is inside the mother. Okay? Fetus hai. But once the child is coming out, the baby is being born, then this needs to close. And if it is not closing, that condition is called as patent ductus arteriosus. So there you use a drug which is your inhibitor of prostaglandin synthesis, which are your NSAIDs. Okay? Don't have any doubt in this. So this is the list of the what are the uses of prostaglandin analogs available, and we'll fill in the indications quickly. So this list would be more than enough for prostaglandins. Don't need to do anything else for this. So ductus arteriosus, the patency is maintained. Okay? Alprostadil. So maintain करने के लिए the ductus arteriosus. To maintain it. To treat the patency, then you have to give NSAIDs. But to maintain the patency, you need ductus arteriosus. GIT, We use misoprostol E1, which is involved in the secretions of those in the bicarbonates and everything, which is protective. So what is the role of misoprostol? I told you, it is a specific drug for NSAID induced peptic ulcer. But drug of choice is your proton pump inhibitors. Now, coming to the reproductive system. So E1 and E2, both are there. So misoprostol, carboprost, dinoprost. Now this have been asked repeatedly. So misoprostol, apart from the above, also can be used for first trimester abortion. Right? We use mifepristone, and along with that, you can use a prostaglandin like misoprostol or gemiprost, which can be used pervaginally. Carboprost is a drug which is used for postpartum hemorrhage. Otherwise, we also use oxytocin, but carboprost is also used for postpartum hemorrhage. Dinoprost is used for induction of labor. L-prostadil in male, it is used for erectile dysfunction. It is used for erectile dysfunction. So these three are very important: misoprostol, carboprost, dinoprost. Okay, so it is used for this purpose. Platelets में prostacyclin, which is the role of prostacyclin, which inhibits in the blood actually. Epoprostenol, betaprost, all of them basically are going to enhance the effect of prostacyclins, and therefore they are all used for pulmonary artery hypertension, right? And iloprost is also used in case of Raynaud's disease. We already have done. These are your prostaglandin F2 alpha analogs, which is used. They are the drug of choice for open angle glaucoma. So this is a list which is important for prostaglandin analogs and its indications. Okay. Coming to rheumatoid arthritis, RA, which biological demand is an interleukin-6 inhibitor used in management of rheumatoid arthritis? So identify the interleukin-6 inhibitor from this. Very good. It is 3. Tocilizumab. ILI is interleukin. Okay? It is an interleukin inhibitor used for the management of rheumatoid arthritis. Now tell me this question which has been asked. Which of the following agent which is used in rheumatoid arthritis acts by increasing adenosine extracellularly? Adenosine extracellularly is typically seen with, yes, it is methotrexate. Okay, it is methotrexate. Yes, as Mani says, methotrexate. So it's the very important drug of choice, or drug of DMARD of choice, rather, I can say. DMARD of choice is your methotrexate. So this chart is important because it tells you, so this is your drugs which are used for acute attack. Acute ke liye we use NSAIDs or we use glucocorticoids. Remember, we cannot use paracetamol because it is a poor anti-inflammatory in this case. Then we have disease-modifying drugs. Can be biological, non-biological. Out of the non-biological, methotrexate is your drug of choice. How it works? It inhibits this Iker enzyme, inhibits the neutrophils. And number 2, it increases the adenosine. So remember these two mechanisms to answer the questions on RA or methotrexate. Then we have, what are the other drugs which can be used? You can remember this mnemonic: Trex left, gold caps. Trex is methotrexate. L is leflunomide. Gold is gold, which is not used currently. C stands for chloroquine or hydroxychloroquine. And you can use cyclosporine. E stands for azathioprine. These are immunosuppressants. Then we have penicillamine. Penicillamine ko remember, this is a drug which is used in Wilson's disease or copper overdose. Wilson's disease. Not in here, we don't use it much. L is sulfasalazine. Sulfasalazine, and sulfasalazine mein we have two moieties. It breaks into sulfapyridine and 5-ASA. Sulfapyridine is used here in rheumatoid arthritis, and 5-ASA we use in ulcerative colitis. Okay. Now, these are the list of your TNF alpha inhibitors. You can remember ICE age. Okay. I is for infliximab, certolizumab, age is adalimumab, golimumab, and etanercept. Okay. So, it side effects is because they are going to inhibit the immune system. So, it can reactivate some diseases like tuberculosis. So, if the patient has latent tuberculosis, it can reactivate it. Then we have interleukin inhibitors. 6 हमने बात किया अभी. That is C6, tocilizumab, and interleukin 1, which is anakinra. CD80, 86 blocker, also cause as a fusion inhibitor. Okay? That is abatacept. Then JAK inhibitors, if you want to remember, anything which is inhibiting the tyrosine kinase or JAK inhibitors, so they will always end with NIB. So we have tofacitinib, baricitinib. So this question is also asked to show you a picture, and this is your bullseye maculopathy seen with long action. So when you give chloroquine, hydroxychloroquine to a less extent, but chloroquine, if you give for a longer period of time, like for years together, they can lead to bullseye maculopathy. So this is the question it was asked. It is associated with medication. So the answer would be chloroquine. Okay. So coming to the next topic in autocoids is gout, another very important topic. So here I have put a picture and you have to identify the site of action of the drugs. So this is site 1, site 2, site 3. 1 pe which acts, 2 pe which acts, and 3 pe which acts. Can you tell me? So 1 is, it is inhibiting the Tariq. Good, Tariq. Very good. What about the others? No, okay. You tell me 1. 1 is probenecid. Very good. 1 is probenecid. Himani, good. Okay. Second, inhibiting the xanthine oxidase, which is the drug inhibiting the xanthine oxidase. Yes, febuxostat. And the last one, which is working like uricase, is rasburicase. Excellent. So this is the correct answer. So either they can ask you this way or they can just show you this picture. And as it was asked last time in FMG, they had marked one area here, xanthine oxidase, and named the drug which is working at this very step. So these are the drugs for gout. Now they are easy drugs which are causing the acute ke liye, you know that we use these drugs. NSAIDs, okay, we use colchicine and we use glucocorticoids. Chronic gout, we use the xanthine oxidase inhibitors, allopurinol, febuxostat. We can use uricosurics, probenecid, lesinurad, sulfenpyrazone, benzbromarone. Remember, with uricosurics, the patient has to be advised to take plenty of water or there will be stones formed. Then the drugs which increase the metabolism by enhancing the effect of enzyme like uricase. So they are recombinant enzymes, pegloticase and rasburicase. Very, very important. Quickly, what are the important one-liners here? Drugs of choice for acute gout, as we already have that. What is the drug of choice? We can use NSAIDs. Agar steroids, then you write steroids. If colchicine is given, then you write colchicine, right? Depending on what is there. Which NSAID is not used in acute gout? apart, let's say if paracetamol is given, that can be an answer also because it is not anti-inflammatory. But the second one, which is contraindicated if they ask you, then that is aspirin. Because I told you low dose aspirin is going to increase the uric acid level. So it is absolutely contraindicated. Paracetamol is not used because it is anti-inflammatory, not anti-inflammatory, but aspirin definitely contraindicated. So drug of choice for chronic gout, yes, that is your allopurinol, xanthine oxide. If the patient is not tolerating or some problem, then you go for febuxostat. Drug contraindicated with 6 mercaptopurines. Which of the drugs which can which is the drug interaction with 6 mercaptopurines? That if you give allopurinol with 6 mercaptopurines, it is going to inhibit the metabolism of 6 mercaptopurine because it is also metabolized by xanthine oxidase. So this can lead to bone marrow suppression. Drug of choice for tumor lysis syndrome. This occurs when you give anti-cancer drugs. So the cells are breaking and there is a lot of purine released and it is converting into uric acid. So we use rasburicase because it is the fastest acting anti-gout drug. And then we can also use allopurinol. Fastest acting, I just told you, this is your rasburicase. So this is recombinant uricase. From the birds it was there, right? And then pegloticase, pegylated. So therefore this becomes very long acting. The major issues with these drugs is they are causing a lot of hypersensitivity reactions. They have to be given by IV route. So that's why not the preferred route. Now, drug of choice for familial Mediterranean fever. This is your colchicine. Okay. So these are important one-liners here. Then off-label drugs will reduce the uric acid. I have told you about losartan. Then there is fenofibrate and a monoclonal antibody. Plus, please remember losartan, at least out of this. Losartan is supposed, you should know about losartan. Okay. So next, we have few points about the serotonin receptors. I don't think I have a question on migraine and all. Yes, that's an important topic. But serotonin receptors are very important topic. And the question can be asked here. So which are the drugs which act on the serotonin receptor? So you see here 5-HT1A, BD, 1F. So these are your agonists in green and the red ones are the antagonists. So what is the use of indication that you have to know? Buspirone, it is used for anxiety. Sumatriptan, we all know it is the drug of choice for acute, severe, not mild, acute severe attack of migraine. Ergotamine, same, acute severe attack of migraine. Lasmiditan is a new drug which is acting on the 5-HT1F. Again, it is used for acute severe attack of migraine. 5-HT2ABC, these are the antagonists. Pibenserine, clozapine, these are your antipsychotics. Right? Atypical antipsychotics. Methisergide was used initially, but currently it is no longer used because it causes pulmonary fibrosis. Remember the mnemonic BBC ban me? Ban me jo one of the drug from M, you can also write methisergide, methotrexate ke alawa. Fibloserine jo hai, it is a drug which can be potentially asked newer drug hai. Flibanserine for hypoactive sexual desire in females. Okay. Lorcaserine. Lorcaserine currently is withdrawn, but yes, it was initially used for obesity. Now it is no longer used because it caused a lot of cancers. Many cancers were induced. So initially it was used for obesity. 5-HT3, all antagonists. Where are they used? In nausea and vomiting. What types? Chemotherapy induced, radiation therapy induced, post-op. Sari nausea vomiting le drug of choice early. 5-HT4, these are prokinetic drugs. So they can be used for constipation. Right? They can be used for GERD or gastroparesis. Remember metoclopramide ke baare mein, this will cross the blood-brain barrier, so never to be given for levodopa-induced vomiting. Okay, metoclopramide it is the drug which can cause drug-induced Parkinsonism. Okay, so this is all about the histamine, this 5-HT table, where various drugs which can act on this. Then quickly about the migraine. So migraine, we know that this was shown in last year, and this picture was shown the radiography. So the patient had migraine and then later on experienced nausea and vomiting, discoloration of the feet and trouble walking. So that means some vasoconstriction was there. Because of this, the blood flow was not going to his legs and or the foot. So there was discoloration of the feet and they were also very cold to touch. So which of the following drugs could have caused this? So which out of them? Very good. So it is ergot. Ergot alkaloids, they are potent vasoconstrictors, right? So they are potent vasoconstrictors. So therefore, they are the drugs which can cause a condition called as ergotism. Gangrene ho sakta hai. So all these conditions can arise because of this. Okay. So can you tell me, out of these, a 28-year-old female has migraine and is pregnant also. And she wants to control her migraine attack. So which out of these is safely given to her? Can be safely given to her? Out of these, the safest drug. Very good. So this is acetaminophen. Yes. Acetaminophen, paracetamol is the safest drug in a said message. But in case any triptan needs to be given, severe attack hai, then the safest drug we have is sumatriptan. Otherwise, we only stick to acetaminophen. Okay. So this is the condition which is the gangrene of the foot caused by ergotism. Okay, ergotism jo ho gaya, ischemic necrosis ho gaya with the help of the or due to this ergots. Ischemic necrosis has occurred, and ergot alkaloids, they are definitely not advised if the patient already has hypertension because it increasing the vasoconstriction. Okay, or angina, or patient has Raynaud's disease. Okay, and gangrene it can potentiate. It can also cause erythromelalgia, nausea, vomiting, very common. That's why it is not preferred. Already this migraine patients have nausea, vomiting, and this will further cause nausea, vomiting in those patients. The action we have done, it is action on the 5-HT, 1D, 1B receptors and cause vasoconstriction and reduce the inflammation. Now this is consumption of a infected crop, which is a rye, which is infected with ergot. No, the Claviceps purpurea, ergot, this is infection, and that can lead to simply intoxicate or toxic effects of ergot in people. Now, triptans are very important because they are the drug of choice for, as I said, for acute, but read beyond acute. Is it a mild case or a severe case? Mild case may only your NSAIDs will be fine. But if it is severe case, then you have to go for triptans. Sumatriptan, as I said, in pregnancy, it is preferred. Fastest acting, okay? Rizatriptan, which is contraindicated in the renal failure. Never give Nara, triptan. Nara, never give Nara in this. Slowest of all, slowest acting. Frova, triptan. Intranasal, what all preparations we have? We have Suma, Triptan. So this is good because if the patient is continuously vomiting in migraine, you have nowhere to give the drug orally. So what you give nasal sprays that way, intranasally. Okay, so you can give that. So that will be effective there. Sumatriptan. And what else? Zolmitriptan. Zolmitriptan. And avoid if there is any of these conditions and should not be combined with drugs like SSRIs, should not be combined with monoamine oxidase inhibitors. Why? Because it can cause serotonin syndrome. Okay? This is important. So lasmiditan, it is approved for acute attack. Okay? That is, we have done. This is what other drugs are there. We have G-PANTs. So we have what others? Zavegepant. Then we have Rimegepant. This has been asked before, a question. So all G-PANTs, they are given for acute attacks. So this one, Zavegepant, is also available as nasal spray. Prophylaxis के लिए, we have ABCD, we have anti-epileptics. And which anti-epileptics? We can give valproate. We can give topiramate. We can give gabapentin. This is for beta blockers. So propranolol, this is the drug of choice for prophylaxis. We can give calcium channel blockers like flunarizine. And we also have CGRP antagonists, which are your monoclonal antibodies. They don't work fast. Fast may we have your G-PANTs and slowly we have your monoclonal antibodies. And it has been asked before, that is your Erinumab, right? Erinumab, Galcanezumab, right? Then we have Fremanezumab. All these are CCPs. D, we can use antidepressants like amitriptyline. So these are tricyclic antidepressants. So D for depressants, antidepressants we can get. So these are the drugs which are important for management of migraine. H1 receptors के बारे में what is important? Let's go through here. We'll go through the quick जो one-liners इसमें पूछते हैं. So remember, second generation are the drugs which do not cross the blood-brain barrier. So they will have less sedation effect. And second generation जो है, they are used for urticarias. First generation is used in a variety of other cases also, like in morning sickness. They are used for management of motion sickness as such. But Parkinsonism, EPS, but second generations only for urticaria. They don't have any other action. So first generation, diphenhydramine, porethrin, because why? They have maximum anticholinergic effects. Maximum anticholinergic action, and they are very, very sedating drugs, and they are used for motion sickness. Motion sickness and extrapyramidal syndrome because of typical antipsychotics. Doxylamine is a drug of choice for morning sickness along with vitamin B6. Cinnarizine, it is used for vertigo. Least sedative, you can use anytime. Which one is this? Chlorpheniramine. Seasickness, long-acting drug, meclizine. Also used as a tricyclic antidepressant. What is the drug? It is doxepin. Okay. Second generation, ठीक है? Second generation, you have to remember which are the drugs with the least sedating. So I think least sedating, which is fexofenadine. Some books also classify them as a third generation. For example, we have desloratadine, fexofenadine. It is a pro-drug, fexofenadine, okay, for estemizole. So this is a least sedating out of them. Most sedating is cetirizine. Most potent is desloratadine. And these drugs are banned because of QT prolongation. Okay, these are banned because of QT prolongation. So desloratadine, fexofenadine, they're also classified as generation third. And these are your topical drugs. So this you can remember once there was a question asked, what are the drugs used for hereditary angioedema? Just remember here the contraindication I was more concerned about. Already there is angioedema in the person. You will not give ACE inhibitors in those patients. So now the last topic for the day is blood. So we are finished with the respiratory autocoid. So now we are quickly going to go through the important topics in the blood. So which of the following is true regarding the iron replacement therapy in iron deficiency anemia? Okay. What is true regarding that? So here one question for anemia for that chapter important is you should know which are the parenteral and oral preparations, and they are given by Z technique. That is important so that there is less diffusion and staining is not there. Any other drug which is given by Z technique is your antipsychotics apart from iron, that you should know. Antipsychotics also given by Z techniques, and iron is also given by Z technique, intramuscular technique, and this is. So here, what is the correct answer? Which of the following is true? So this is here the correct. Before parenteral iron, you should dilute the dose to give a check because iron can cause in some people hypersensitivity reactions. So this is important here. So this is the true. Here parenteral iron will be given till the hematocrit normalizes and should be discontinued afterwards. No, you still must continue for 2 months. Even after your HB or hematocrit is normalized, still you need to continue for 2 more months so that the stores are also filled. 50% of iron given is absorbed in this, not 50%. I think 12 or something. This is the only percentage of iron which can be absorbed from the oral tablets. Because of the side effects of oral iron, always give parenteral? No. We always start with oral iron first. If patient can't tolerate, then only we switch on to the parenteral. Parenteral is not your first choice. It is the first is always your oral iron. So which condition? It can be a pathopharma question overlap. So what is the condition seen here? Basically, it is megaloblastic anemia. And what is the drug of choice for megaloblastic anemia? That from here you give folic acid. Okay. Now, here, vitamin B12. What is this? Cyanocobalamin, hydroxocobalamin. So remember, हमने किया था hydroxocobalamin. It is used for cyanide poisoning. Okay, remember this this cyanide poisoning. के लिए what we use hydroxocobalamin. That is more important here, and this is used for megaloblastic anemia. Iron preparations, iron dextrin can be given IV, can be given IM. This is only IM, and as I said, Z technique. Any other drug which is also given by Z technique IM? Yes, this is your antipsychotics. Folinic acid, it is responsible for not folic, but folinic acid for methotrexate toxicity. These are your hematopoietic agents. Again, they are asked which is given when. So your erythropoietins, epoetin, darbepoetin is used in anemias, whether it is because of chronic kidney disease or whether it is because of chemotherapy. Then GCSF, sorry, it is filgrastim, pegfilgrastim and lipifilgrastims. All these grastim, So जो grastins हैं, they are GCSF, and they are given where in case of neutropenia. Neutropenia because of chemotherapy. Gramostims are GM and granulocyte macrophage colony stimulating factors. So they will also be given in case of neutropenia. Thrombopoietin agonist. We have L-tromobag. So this is throm here, thromboplastin, and यहाँ पे it is plastin, romiplastin, L-trombag. This is given for idiopathic thrombocytopenic purpura. Interleukin 11 analog. It is oprelvacin. ELEV is 11. Okay, 11. Interleukin 11. Interleukin analog oprelvacin. So what you do is you give it in case of thrombocytopenia, in case of chemotherapy. So this is an important table to remember. Okay. So there is a patient who is suffering, who has been given anticoagulant therapy, and she delivered a baby. And what you see here is this baby. So what is the drug which has caused this? So we have discussed this picture before also. This is called as nasal hypoplasia. Okay? Nasal hypoplasia. And the condition which, or the drug which causes this nasal hypoplasia is warfarin. So this is fetal warfarin syndrome. ये सारे conditions होते हैं. So there is hypoplasia of the nose, and there is short limbs, there is hydrocephalus. So all this is a part of fetal warfarin syndrome. Okay. So for warfarin, what is important is that it takes time. It has a lag period. It doesn't affect immediately because it inhibits the formation of factors 2, 7, 9, and 10 along with proteins C and S. Okay? So 2, 7, 9, 10, then along with that. So therefore, already formed clotting factors will not be affected. So isliye there is a lag period, cannot use it for immediate effect. You have to start heparin with it. First factor to go is factor 7, and the last factor, this is important, which is the first factor to go, that is factor 7, and the last factor is factor 2. Then this is a side effect which is seen with warfarin, dermal vascular necrosis. As I said, can't use is acute case. You have to start heparin alongside. And how to monitor? We monitor this by INR. This is the normal range, and you monitor with INR. And if there is bleeding, what you give? If it is less, INR is less than 10, you simply can stop warfarin. But if it is more than 10, you have to start vitamin K also. Vitamin K is the antidote for warfarin. Start that. If it is profuse serious bleeding, then the drug of choice is 4-factor plasma. It's very expensive otherwise. So if there is serious bleeding, then you give 4-factor plasma. All these 4 factors which are missing, you give it alongside. And this is a purple toe syndrome. And this is asked, what is the reason for this? This is purple foot or purple toe, you can call warfarin. Warfarin causes this. So this is the picture shown, and identify the drug causing this. Other drugs, don't remember the names only for direct thrombin inhibitors. That is dabigatran. But we don't need any monitoring, no monitoring. So this was asked recently, which of the following drugs needs no monitoring? So dabigatran needs no monitoring. Direct factor 10 inhibitors will have 10 in their names. Okay, for example, rivaroxaban, okay, apixaban, okay, apixaban, all these. So XA, 10A, 10A. And this is, just remember, this is a antidote, but it is not specific. It can work against all of them. Siraparatang, so it is not a specific antidote. So just the name is okay. So this was a question recently asked, as I told you, which of the following does not require monitoring? So it is an oral drug and it does not require monitoring. Okay. So monitoring is required where? Monitoring is required in all these. Parenteral, इसमें require है. What is the monitoring? APTT. Heparin requires APTT. Warfarin requires INR. Not required here. Dabigatran, not required. Low molecular heparin, only required if there is a renal failure. Otherwise, not required. But this is only required if there is a renal failure. So this one. Heparin, drug of choice in pregnancy. We don't use warfarin. We use here. Antidote, I told you already, it is your protamine sulfate. And what are the major side effects? So this is a mnemonic, bleeding hota. Bleeding hota. Bleeding is itself is a side effect. HOTA. H stands for hyperkalemia. O stands for osteoporosis. 3 stands for idiopathic thrombocytopenia, or we get HIT syndrome, HIT. This thrombocytopenia. And A stands for alopecia. So another question, what is the treatment for HIT syndrome with heparin? The drug of choice is ergotamine. Okay. Now, this is a question of patient on antiplatelet therapy. He has reflux esophagitis. जिसके लिए A for in this alopecia. Sorry for the right. Alopecia. Okay. A for alopecia. So a patient on antiplatelet therapy was complaining of some reflux esophagitis and he was given omeprazole. Then it was seen patient suddenly developed slurring of speech, numbness in the limb. So what could be the reason? Because this is because of decreased efficacy of the antiplatelet. So what was the most likely drug here? So remember, when we did enzyme induction inhibition, there is an important, very good, it is clopidogrel. This is an important drug interaction. Omeprazole is never to be given with clopidogrel because it will inhibit the activation of the clopidogrel. So you can give other drugs, you can give rabiprazole and all, but not this. Okay. A patient of CVA was prescribed antiplatelet, which is a competitive antagonist. So they have given you the mechanism. Competitive antagonist of thrombin receptor. What is true about this drug and its features? Can you tell me what is true about the drug and its features? So here you have, what are the thrombin inhibitors? Anything which have Vorapaxar, Atopaxar. So Atopaxar currently we don't use. So Vorapaxar, it has nice. So it was one of the INICT exams. So remember, is as such. Isko aise hi ratta maan lo, so don't go into the depths. Vorapaxar has 90%. Any such questions which doesn't have any, like remote connection has been asked once in a while, please remember that question as such. You don't have to go in depth into that. You possibly can't remember for everything what is the T-half, what is the bioavailability. So remember as such. So the answer is Vorapaxar has 90% bioavailability. So your antiplatelet drugs only will briefly, I think 1 or 2 slides are there and we'll finish off. Inhibitors of thromboxane A2 synthesis. This is your aspirin. Okay? This is your aspirin. So this is your platelet and these are the various areas on which the drug can act. So here this is inhibited by aspirin, COX inhibitor. Okay, it is. Then we have inhibitors of P2Y12. These are the ADP receptor. So your ADP is released and it acts on this receptor P2Y12. We have reversible like ticagrelor and we have cangrelor. Irreversible like clopidogrel, prasugrel, clopidogrel. So this is working here. GP2B3A. Now these are one of the most effective antiplatelet drugs. And so remember T as the mnemonic. We have tirofiban, eptifibatide, and A is epsiximab. Okay, so these are the GP2B3A. So these are the receptors for which are going to form fibrin. Fibrinogen ke liye this is a receptor on the platelet and they are going to form fibrin. So these are tirofibin, eptifibatide and epsiximab. Protease activated receptor, PAR1. So this is the thrombin receptor, protease activated receptor. So only one drug because atopaxo we don't use anymore. So we have vorapaxo. And phosphodiesterase inhibitor is the inhibitor which inhibits this step here. And it increases the level of cyclic AMP. So whenever cyclic AMP is increased, they have anti-aggregatory effect. Whenever ADP is increased, they have pro-aggregatory effect. So when you inhibit phosphodiesterase, cyclic AMP pe action. Now this is the inhibitor phosphodiesterase, which is called as dipyridamole. Antiplatelets dipyridamole. Okay? So GP2B3A, they are the strongest. Question is strongest of all. It is your GP2B3A inhibitors, these ones. And out of this eptifibatide, it is the shortest acting. Eptifibatide is the shortest acting. Protease inhibitors. So this one not used anymore. Then these are your P2Y12. So remember the interaction between clopidogrel and the omeprazole. Omeprazole inhibits this enzyme, so clopidogrel is not activated. But what you can do instead, you can give rabeprazole and pantoprazole. They are not inhibiting the CYP2, C19, and this one. Okay. Okay. So the last one the last MCQ, all are true about thrombolytics except. All are true about thrombolytics except. So this also, remember this one. So don't need to just remember this MCQ as such. So if you're asked this way, tenecteplase is susceptible to plasminogen activator inhibitor. No details are required for this. So remember as such, tenecteplase is susceptible to plasminogen activator inhibitor. Because altiplase, what is altiplase? Let's see here. What is altiplase? So altiplase is clot specific. It has less risk of bleeding. Okay? And out of this, which is the shortest acting, is altiplase. Therefore, shortest acting will require IV infusion. Okay? So this is true. Altiplase requires IV infusion, shortest acting. All the others are long acting. So you give bolus and then forget it. But altiplase, it will require continuous IV infusion. If there is an overdose because of this drug, then you give antifibrinolytics. For example, you can give tranexamic acid or EACA. Right? So this is the overdose for fibrinolytics is antifibrinolytics. Streptokinase, the problem is it is highly antigenic. So if patient develops hypersensitivity reactions, you can't use it again. Urokinase, expensive, not available as such, right? And they have to be given within 3 hours of any stroke, etc. So only then will they be active. Okay. So finally, 704, we have managed to finish blood also alongside. Doses, no dose is required until unless I will tell you jahan pe dose hai. Because there is I'm not sure about medicine, but pharma mein the drugs you have to remember. Okay, don't go for so many doses and all. You will hardly find doses being asked. Don't waste time on that. Wherever there is a dose asked, I will tell you like there are certain conditions. So only see there is so much otherwise to learn and to remember, right? So guess don't do anything apart from this. It's a lot of I think content, right? So yeah.